they are still in, they have their clouds of doubt about the quality of oocytes and how to go about managing everything. So there's a plenty, but there is still a doubt of whether they are good enough for a pregnancy or not. And as we all know, PCS girls and women face so many problems, anxiety, mood swings, depression because of their acne, pimples, everything. Apart from that, their irregular cycles and obesity, and it is really tough to handle. And it's like the hand is full and yet it is empty because there is nothing left in hand at the end of the month. So too many follicles, too many cysts, and no eggs. So how to really deal with these overloaded ovaries where more is not really merry. So handling the overloaded ovaries, more is not always merry. That is the theme of our webinar today. And I welcome you all for this wonderful webinar. We have a galaxy of speakers. So the first speaker, I welcome Dr. Sachin Kulkarni, who will be speaking on hormonal regulation in PCOS and how we can, just by correcting the hormones, we can prevent the woman from undergoing this cycle of IVF, and how she can attain pregnancy even with just a bit of hormonal regulation. So welcome, Dr. Sachin.
Thank you so much.
The next speaker would be Dr. Manju Jilla ma'am. Welcome, ma'am. She would be telling us about the stimulation protocols. As you all know, I mean, the picture here could be self-explanatory, how it is a tightrope on how to deal with stimulation, selecting the proper stimulation protocol for a PCOS woman, PCOS patient. It is a tightrope of how to go about it because of all the repercussions and the consequences that such a stimulation may lead us to with OHSs and all that. So what is the proper stimulation protocol? Dr. Manju Jilla would be speaking, and it would be really wonderful to know her insights into this topic. Then the next topic is medication. So apart from the stimulation, the gonadotrophins, what are the other medications that are used in PCOS? And to enlighten us with that, we have Dr. Professor Shweta Mittal Gupta. Welcome, Dr. Shweta. She is also the Secretary General of IFS. So it is really an honor and pleasure to have Dr. Shweta Mittal with us, who would be speaking on the medication in PCOS. And finally, I think whatever we may do, it is how and when and what trigger to give to the patient so that we get the best quality of eggs and good embryo quality with us. So to speak on this very important topic, we have Dr. Sharayu Mohite. And so we have 4 speakers speaking on very interesting topics. So welcome once again, Dr. Sachin, Dr. Manju, Dr. Shweta, and Dr. Sharayu for this webinar on behalf of IFS Vidarbh chapter. And then also our chairpersons, Dr. Sushma Deshmukh, Dr. Manju Shriboob, Dr. Shilpi, and Dr. Ritu Dargan, who would chair the sessions and take it forward with their questions, and they will give more depth to the lectures that we hear today. So welcome to all our chairpersons. And so eventually I would say that all the rain that we see in PCOS, I hope that it is a fertile rain. We get good quality eggs leading to implantation and pregnancy. With that, I, Dr. Bindu Chimote, Secretary IFS Vidarbh chapter, along with my Joint Secretary, Dr. Manish Baheti, welcome you all to this webinar, and hope at the end of the session, every woman can say that, yes, are you fertile? Yes, I am fertile. I can attain fertility with a proper management, clinical management. And let us all hear from all our speakers today. So welcome once again, and we begin the webinar. Thank you so much for being here. And of course, to take the entire session forward, we have our wonderful MOC, Dr. Riju Chimote, so who will, take the thread forward from here on. So welcome, Riju, and the stage is all yours from henceforth.
Thank you. Thank you so much, ma'am.
Okay.
So as Albert Einstein once said, in the middle of difficulty lies opportunity. Managing PCOS with a focus on hormonal regulation presents us with opportunity to prevent invasive treatments and ensure holistic health for all our younger patients. It's not just about choosing the right protocol, but also individualizing care for each patient to achieve the best outcome. And this is what our first session is all about. And to chair the first session, I would like to invite our chairpersons, Dr. Sushma Deshmukh ma'am and Dr. Shilpi Sood ma'am. Sushma ma'am is immediate past secretary, IFS Vidarbh chapter, past president, NOGS, director, Central India Test Tube Baby Center, a well-known for hysteroscopy and international hysteroscopy carnivals, author and a beautiful poet. Welcome, ma'am. Our next chairperson is Dr. Shilpi Sood. Ma'am is the managing director of Safal Hospital and Diva Fertility Center, past vice president NOGS, past chapter secretary IFS Vidarbh chapter, recipient of Dhanvantri Award, and was invited for FIGO Paris for clinical application of pelvic anatomy. Welcome, chairpersons, and I request you to kindly take forward the session. Thank you.
Can you share this slide?
Yes, ma'am.
CV slide. A very good evening to all. At the outset, really, welcome to all. Welcome to all the renowned faculties. And really, it's a PCOS month. And it is needed that importance because we all know that the PCOS is a burning issue of the world. Nowadays, even the percentage has gone more than 22%. So really, it is very important to learn about PCOS because whenever you utter word PCOS, so many things are coming to your mind. It's a heterogeneity, thief of femininity, with always instability, hormonal instability, and so many issues. So today we are having wonderful speaker, Dr. Sachin Kulkarni. He's a fertility consultant at Sunanda IVF Kolhapur and Jahangir Hospital, Pune. Principal faculty at IBC Reproductive Medicine Certification course at Dubai, UAE since 2013. He has a research, wide experience of the research. There's a changes in diet composition and urbanization and its effect on the polycystic ovarian syndrome phenotype in a Western Indian population. So, and really, I know Dr. Sachin sir since so many years, and his academic touch to every aspects. Whatever is there, all academics, the name is Dr. Sachin Kulkarni. So it's a really honor for us to listen from Dr. Sachin Kulkarni. So, sir, please. He is going to speak on hormonal regulation in PCOS and preventing IVF in young women. So, stage is yours.
Thank you so much. Thank you so much for the kind words. Let me just share the screen first. Yeah, thank you so much, IFS and Vidarbh chapter of Indian Fertility Society for placing this invitation to me. It's a real honor to share the stage with Shweta Gupta madam and Jila madam, everybody. And Sushma madam, we met after a long time online, but very happy to see you. Manjushri Boob madam also, I think long time back I had met in Amravati. After that, not met, but thank you so much for this invitation again. I'm going to just dwell into some pathophysiologic mechanisms of polycystic ovary syndrome with all of you, and a few papers on whether prevention really works for these women. I'm going to, the slide change doesn't happen, so I'm going to keep the slide up. I don't know why it doesn't function on my iPad like that. So let me do it this way. A polycystic ovary has two kinds of origins as a disorder. And it has
pathophysiology. Excuse me, please. The other people, please. Excuse me.
Okay. Thank you so much. This happens.
Sir, your voice is loud.
Do you want a louder voice than this?
Yes, louder voice, sir.
I'm trying my best.
Can we please request all those who have logged in to keep yourself muted?
Please mute the other doctors. Please mute their mobile or laptop because it will be disturbing for the faculty. Please. Sir, please.
It's okay. Thank you so much. Yeah. So basically, the PCOS has two kinds of origins. One is a genetic hit, and second is the environmental hit. The genetic hit will start intrauterine, wherein there would be endocrine disruptors, or there could be an AMH excess in the baby because of a high androgen which comes from the PCOS mother transplacental to the baby. And this high androgen will cause a lot of proliferation of the primordial follicles, which will become preantral, and they would have excess amount of AMH secreted. So in short, the baby, which is destined to be born by about 1 to 3 million of follicle, she will be born with maybe 5 to 7 million. I mean, this baby will be destined in future as she becomes an adult into polycystic ovary syndrome. And there is obviously an environmental hit, which is very commonly seen. That is the insulin resistance and obesity that comes because of lethargy, stress, because of sedentary lifestyle, etc. And that obesity added will exaggerate an existing a milder PCO-like features will also get exaggerated. Sometimes obesity itself causes anovulation and polycystic ovarian morphology kind of picture, and it will be a phenotype D kind of PCOS induced entirely by obesity alone. So in the lifespan of a polycystic ovarian girl, it starts with an hyperandrogenic secretions in the as an adolescent lady, and it goes into infertility in the middle age, and later on it becomes more of problems with reproductive disorders. So initially it could be a presentation of acne, hirsutism, irregular cycles, infertility to follow as she gets married and tries for a baby. By 35 to 45 years, she's been exposed to a lot amount of estrogen, and there is a problem of adenomyosis, fibroids, and metabolic complications like type 2 diabetes mellitus, cardiometabolic problems like hypertension could also be there. And very late, beyond 50 years, because of obesity and a high estrogen for a long time, she is at risk of developing endometrial and breast malignancies as well, and suffering from cardiovascular accidents. Cardiometabolic risks are very high. So at a different age, a polycystic ovary will present to us in different fashions. So we commonly see in our practice an obese polycystic ovary syndrome patient or a lean polycystic ovary syndrome patient. I'm not going to go into these graphs, though they look interesting. The common presentation to us is this. You will have a high AMH polycystic ovary who is lean, tall, and she has high LH also, and insulin resistance and androgen could be added to that story, and they will spoil the picture. Could be a high LH obese one with a moderate AMH, and again, as the insulin resistance worsens, androgens also increase and she goes worse and worse. Or you could have an obese lady with a normal LH and she more of has a polycystic ovarian morphology. So I'm going to discuss today something on AMH, some parts on LH, something on fat distribution, and what could be the preventive strategies. Obviously, lecture cannot be complete in about 20 to 30 minutes. I'm just going to try and pick up a few things and present to you. I'm sure there will be lacunae in the knowledge because all the papers won't be covered and there's a huge amount of literature published. I'm going to talk of AMH, and AMH is so well known to all of us, and that's our basic investigation, like a hemoglobin test we do. Can there be a cutoff of AMH? The studies and the systematic reviews published earlier said that if you have an AMH level of 4.5, that can be a universal cutoff to identify a PCOS lady and a non-PCOS lady. But then there has to be an age-specific AMH for polycystic ovary. For a younger lady, even if the AMH is 4.5 or more, they could be still normal women with a high responding or high ovarian antral follicles. So the AMH at a younger age, between 20 to 27, cutoff is 7.4. That of in middle age, from 27 to 35, is 5.16, and that beyond 35 could be 4.7. Now, this is one study published in Iran by this author who is highly publishing on AMH, especially how it is related to menopause, etc. So this could be an Iranian ethnicity. The same age-specific cutoffs for AMH for polycystic ovary diagnosis could differ in the Indian population. It's high time that societies like IFS and ISAR come out with nomogram of age-specific AMH in India, so that in general, the diagnosis of PCOS will be more simple. Then the importance of AMH is that it is an aromatase inhibitor. Because it is an inhibitor, you require a higher emphasis for stimulation. This is one simple paper published in 2016. They actually looked into the data of Richard Legros publication of clomiphene and letrozole in polycystic ovary, and they look at this. Whenever they had anovulation, no ovulation, the AMH was higher. Ovulatory women had a low AMH. Come look at the antral follicle count. The antral follicle count does not correspond in a similar fashion. So geometric mean for a non-responder would be in 7.35 of AMH, and that of responder is 5.54 in a PCOS population. So what the information we gather out of this is, whenever there is a high AMH, you will have clients who would have an AMH beyond 10, could be 16 or 20. Do you go for straight for IVF for these women? Probably not. We still go stepwise fashion, because the guidelines do not recommend to go for IVF directly. When we are going a step-line fashion and we're looking at a client who has a high AMH, it's better to counsel them that you have a high AMH, we're going to go stepwise, and there's a possibility you manifest anovulation in spite of this treatment, and then we will increase the steps in a slower fashion. It is better to do this way rather than increase the dosage suddenly and face hyperstimulation. But this is one more fact we have to know about. Elevated anti-Mullerian hormone is an independent risk factor for preterm birth, and this is not commonly discussed. AMH in the intrauterine life is a pro-apoptotic hormone on the Mullerian system. AMH receptors are also seen in myometria, and there is a possibility that gathering of the mesenchyme to form the myometrium could be limited because of a high AMH, and that is one of the pathophysiological mechanisms have been described. So high AMH women by itself are at risk of developing preterm labor. What about LH and how we understand LH, how it affects the PCOS pathophysiology? LH pathophysiology, why LH is high? That's the most important question. LH responds to GnRH. So the given pulse of GnRH, which comes from the hypothalamus, and excess of LH is released. And this has been diagnosed because lately, about a decade back, they found AMH receptors even in the hypothalamus. So why an AMH receptor could be there in hypothalamus? And probably they say that there's a possibility that AMH could be regulating how much LH is released for GnRH pulsatility. Obesity independently, where I have high androstenedione. With high androstenedione and peripheral aromatase enzyme, it will get converted to estrone. Estrone is a very weak estradiol, but the amount of obesity is very large. So collectively, the estrone is high. So this lady is the high estrogenic stimulation, which will act on the pituitary, and the LH will go up. But this LH has no follicles down to act and luteinize sometimes. So you'll just have a hyper LH, and that will increase the androgens as well. In these PCOS women, there's a particular thing that LH is not suppressed adequately by rising E2 and progesterone. We see an antagonist cycle, your day 2 LH and day 6 LH, the LH would have come down because you have stimulated them and your estrogen is going up. But that doesn't happen here because in the intrauterine period, the baby could be exposed to a high androgen level that somehow changes or attenuates this response of the pituitary to the rising androgens and the other hormones. The last is insulin resistance. With insulin resistance, the insulin growth factor binding protein 2 decreases. That causes increased amount of IGF is available. IGF-1 is available for the follicular genesis. IGF-1 and androgens together will cause the follicular growth, and that also acts to a pathophysiology of PCOS. Increased mean LH pulse frequency and amplitude is seen in PCOS women. That could be one more reason of high LH. LH will also increase androgens, and that's the reason why this is called a functional ovarian hyperandrogen. When Rotterdam criteria were introduced, the Germans themselves were not in sync. The one group was not syncing with this Rotterdam criteria. They said that we are over-diagnosing, and they said we need to classify polycystic ovary as functional ovarian hyperandrogen. My humble request to mute. Somebody is not muted. My humble request to you.
It's really a request to everyone. Please mute your laptop.
Okay.
It's very
Now, a functional ovarian hyperandrogen, we say that, typically this high serum LH will act on the ovary will produce more androgens. But that may not be the only reason. Obese polycystic ovaries have normal LH, but still they are hyperandrogenic. So what actually happens is there is desensitization of theca cells to LH. So as the LH increases, to a certain amount, the theca cells will keep producing androgens. But after that, there is desensitization. And just because of high LH, the androgen secretion will increase. But the problem in obese is with hyperinsulin, this desensitization escape and the androgenicity is mentioned. So it is a combo of LH and obesity that works together to increase the androgen synthesis. High LH because of abnormal sex steroid feedback. So LH pulse frequency is not sensitive to the negative feedback of estrogen progesterone, as I discussed, and androgens intrauterine will attenuate the negative feedback, and hence LH will be very high. So prenatal exposure to excess androgens, there is AMH receptor in the hypothalamus. It sets in more LH release in response to normal GnRH curves. So what are the important LH clinical practice? In our clinical practice, this is what we follow. If there is a low LH, that the LH is less than 1.2 or 0.8, we preferably don't like to start stimulation because we want to start stimulation on a good LH pool so as to get good output. We all understand your empty follicle syndrome and all are related to low LH at the start of stimulation. A threshold LH that is between 1.5 and 9 is very well accepted by all of us. A hyper-LH is some LH beyond 10 on day 2 or day 3 of the cycle. Premature luteinization is when the progesterone level is beyond 1.5, and LH surge is when LH is beyond 17 mIu. There are various different definitions of LH surge. I'm just taking one to understand it better, but there are many more definitions of LH surge as well. What about obesity? So let's understand the insulin story. So when they did the basic studies, culturing the granulosa cells with testosterone-rich media did not increase the insulin levels. But culturing the granulosa cell with insulin-rich culture increased the testosterone levels in the culture. So if we understand this well, the treatment intervention should be targeted at decreasing insulin and not at decreasing testosterone levels. Insulin resistance in polycystic ovary syndrome, insulin-mediated glucose uptake is reduced, but steroidogenesis is high. You have to remember the steroidogenesis is still kept high. Insulin augments LH-stimulated testosterone production. Increased insulin upregulates LH binding sites, and insulin increased estrogen progesterone production from granulosa cells also there. On top of that, your non-alcoholic fatty liver disease is commonly seen in hyperandrogenic high insulin resistance patients in polycystic ovaries. Suppose we want to go for weight reduction. If you want to go for weight reduction, our weight reduction has to be beyond double digits. Only if there is beyond 10 kg of weight reduction, top quality embryos will be high. PCOS women obviously have a lower implantation rate because of control, because of many more reasons. And only clinical pregnancy rate were better in women losing beyond 5 kg. But look at that, it is clinical pregnancy rate. They are not mentioning live birth rate. That means they do suffer high obesity, high insulin resistance, induce more miscarriages. Insulin suppresses IGF-BP1, hence insulin growth factor 1 increases, stimulating theca cells to produce more androgens. Obesity also decreases IGF binding protein 1. Insulin resistance, most important, it suppresses SHBG. And estrogen is increased. And SHBG, while testosterone suppresses the SHBG, but this is that. Now, let me tell you the story of this little more. When we diagnose hyperandrogenism in PCOS, commonly we will do free testosterone or maybe an androstenedione level. The free testosterone is recommended by the Barcelona criteria. Androstenedione level is not recommended. But believe me, the marker of hyperandrogenism in polycystic ovary syndrome is a low sex hormone binding globulin. So we have to get a holistic picture of doing testosterone, androstenedione, and sex hormone binding globulin. I generally rely on sex hormone binding globulin more. My generally cutoff is less than 20 SHBG is a more hyperandrogenic reading. Anyway, decreasing the androgens before any treatment is not the motto of our treatment. What we understand, somebody who has a high androgen is the one who is a severe polycystic ovary and will require a higher stimulation. Again, Hashimoto's thyroiditis is more commonly seen. Insulin resistance, polycystic ovarian hypothyroidism is very commonly seen in our population. 1 in 7 PCOS could be hypothyroid if we apply the older criteria of subclinical hypothyroidism. The newer criteria of 2024 of subclinical hypothyroidism by ASRM, it is TSH-RIP. We will talk of that sometime later. 20% of the PCOS will have prolactin. Very important to know. Many doctors will just do a fertility test and prolactin will be done routinely. The prolactin will commonly come between 25 to 40 in a PCOS because of a hyperestrogen. There is more lactotroph proliferation and your prolactin will be high. So the cutoff of treating hyperprolactinemia in PCOS will be anything beyond 40. No point keeping 25, otherwise we'll be treating everybody. Prolactin will inhibit SHBG and it positively correlates with TSH. Low prolactin obviously is associated with higher metabolic syndrome. Now, herein, I just want to say that your sex hormone binding globulin or your hyperandrogenism or insulin resistance are proportional to each other. Like a high insulin resistance means low sex hormone binding globulin. A high insulin resistance also means there are more oligomenorrhea. So the number of menstrual cycles a lady gets in a year is inversely proportional to the insulin resistance. So higher the insulin resistance, less is the number of menstrual cycles in a year. So she could be having just 4 or 3 menstrual cycles in a year, but she's very, very obese. As you control this, your number of cycles will improve. Now, this is again very important. Why this is important? When it comes to obesity management, just giving anti-obesity medicine will not work. If you give pragmatic progesterone and get cycles every 35 to 40 days or 30 days, and that would also trigger better control on the metabolic syndrome. We all use metformin, and metformin inositol is favorite for everybody. That improves insulin resistance for sure. But does metformin and inositol make a huge difference in the endocrinology of the PCOS? Will it improve the outcome later? We really don't know. The studies are not strongly saying that. Metformin does not increase clinical pregnancy rate in IVF and ICSI. Androgen levels, few of the studies are saying metformin does not make any difference for androgen levels, but few studies say that androgen levels can decrease modestly. I think the studies which say the androgen level decrease are basically done with a prolonged metformin. If you do metformin for just 2 and 3 and 4 months, I don't think the androgen levels will improve. So I think metformin and inositol are more responsible for correcting the metabolic story of polycystic ovary. The endocrine story does not get corrected. Metformin can be offered in PCOS pregnancy to decrease androgen passage to fetus. I think this is very, very important. That we should be giving a metformin in PCOS pregnancy so that if she has a female fetus, her androgen passages will decrease and probably future improvement would be there. And there's a nice study done by Ichiburo in 2020 that metformin protects offspring from DNA methylation changes because of increased leptin levels, and adult onset disease could be prevented. And again, there are the pediatric studies have been done. We talked about metformin in pregnancy and what happens to the babies in the pediatric age group. Obviously, they have no cognitive function problems, no miscarriages, no preterm labors. So metformin is pretty safe during the course of pregnancy. So what could be the newer therapies to prevent a polycystic ovary requiring an IVF? And interleukin 22 is coming up, just proven in animal studies that it improves insulin resistance directly, and it corrects the estrous cycle. It's a spelling mistake. The estrous cycle in mice, but human studies are not yet there. But kisspeptin neurons is a new target, and this fezolinetant, which is available, which is a neurokinin 3 receptor antagonist, and that could suppress the androgen and correct LH levels, and this will improve. I commonly see a lot of clients having hyper LH, and they're mistreated by giving OC pills, or they're mistreated by giving antagonists for 3-4 days. But all that just does cosmetic effect. Why your high LH or high AMH or high androgens are bad? Because they are making the antral follicle a very androgenic milieu. And you need to convert androstenedione into estrogen. So if you have a very high androstenedione level, you will require a higher induction of aromatase activity to convert it to estrogen so that the follicle grows further. So they just tell you that this polycystic ovary is resistant, she is going to require a higher dose. You don't have to correct your AMH and LH, then start stimulation. You just require to give higher dose. So when all we can intervene so that we don't have to go IVF. You can probably intervene as early as in a PCOS pregnancy. A PCOS mother pregnant, well, you can start metformin, and that would decrease the androgen passage. When it is about 16 to 24 years or till pregnancy is planned, well, lifestyle and diet is the core, and everybody has their own masalas and nuskas for giving a lifestyle treatment on diet, and you people are more experienced, and they would definitely make a lot of choices are there, like intermittent fasting, carb-free, keto, whatever it is. You can practice whatever is giving you the best result and do it up. Prior to embarking fertility treatment, obviously, again, lifestyle is very important, vitamin D supplements, diet regulation, and obviously a role of GLP-1 agonists like semaglutide, Ozempic, or your liraglutide has to be known further. I would say, whenever we are giving a diet counseling, never give diet counseling to the lady in front of you. Give diet counseling to the whole family, or the who cooks, the mother and everybody in the family need a diet counseling. So, with a laddu full dabba full of laddus, even I can't avoid that. Let's look at a few papers. So the effect of weight loss before IVF, and this is a systematic review and meta-analysis. And we obviously say that weight loss will do very good. But believe me, weight loss does not improve ovulation induction results. Okay? The trial which has been done is a randomized trial by Richard Legros et al. They did about 18 months of weight loss program and 18 months of ovulation induction. Ovulation induction group was a control group. The treatment group was a lifestyle and weight loss group. The control group, that is the ovulation induction group, achieved pregnancies much faster, and the time to pregnancy was less. But obviously, this is not a good practice point to convey our patient. Don't lose your weight. We have to keep up a good practice point. We have to tell them lifestyle, lifestyle, and lifestyle. Because lifestyle may not change the ovulation induction or IVF outcome, but it will definitely make changes going towards a better live birth rate. So when it comes to pregnancy outcome, your weight loss is very important. Probably when it is related to an IVF outcome, weight loss may not be that great outcome. That's what the evidence is saying. So in this case, the weight changes with intensive diet restriction over just about 5 kg and with medication was about 2 kg. Only single digit difference, that doesn't make any difference. And the systematic review says the live birth rate, your odds ratios are crossing the line of unity. In the clinical pregnancy also it is crossing the line of unity. So it doesn't make any difference whether, so ovulation induction, rather, when I see a obese lady, I just convey her, well, your simple things may not work. You may require to go for higher doses, and I need to overcome the obesity related resistance to your ovulation induction. What about the glucagon-like peptide? And this is something which we use very commonly. I'm very happy. Initially, I was using liraglutide because semaglutide was not available to us. Ozempic is still not available in India as an injection, but Rybelsus tablets are available. Start with 3 milligram of Rybelsus tablet in the morning at 6 o'clock, and she takes it about 120 ml of water. And after that, for 1 hour, she doesn't have anything. After about 3 milligram of 15 days, she gets used to it. We can increase the dose to about 6 milligram. Most of the patients will require 6 milligram. The complication is it delays gastric emptying. Because the gastric, she will have a sense of fullness. Some people may feel a bit amount of retching. Otherwise, very rarely gastroparesis may be noted. Otherwise, very, very safe medicine. Definitely improves a nice pharmacotherapy. So a combination of this pharmacotherapy with cognitive behavior therapy and a diet counseling, all three together will definitely work towards getting the weight down and making her a better PCOS. Because in a PCOS lady, I always tell her that you are in a spectrum. I have to do all the investigation to find out which part of the spectrum are you in. So after the investigation, if I know you're on the severe side of the spectrum, we need to give you something to optimize you to come on the better side of the spectrum. And I always compare that to a spectacle. You know, somebody who has a 0.5 number spectacle, he may not even wear it. And somebody who has 8 number will have to wear to see a dream also. So where you stand on the spectrum is very important. And your therapies of these obesity control, everything can push the client on a downhill and obviously improving the pregnancy outcomes later. Ovulation rate and menstrual frequency definitely increase with weight reduction. There is increased natural pregnancy rate, but increased IVF pregnancy. Herein, I want to say that we will counsel somebody who has an obesity-related or obesity-aggravated polycystic ovary that your weight reduction will give you a natural pregnancy. Somebody who has an AMH of 20 and she is 90 kg, believe me, her weight reduction is not going to improve her pregnancy rate unless you go for something like a bariatric surgery. I'll come to that. So what about bariatric surgery? And this is a nice paper of in vitro fertilization outcomes after bariatric surgery. Now, the problem is that women have a high expectations of regaining fertility after bariatric surgery, but obesity related to infertility is not yet an indication of bariatric surgery. But still, women or even the teenagers would go for a bariatric surgery who are beyond 100 or 110 kg. And for such women who are beyond 90 kg, your diet control and pharmacotherapy cannot get a double-digit weight down. Even if you get the double-digit weight down, but 10 or 15 kg, their metabolic syndrome may not improve to a great extent. And they may get pregnant, but the chances of live birth rate are still low. So bariatric surgery is something we need to be very proactive about, nothing wrong in it. And there are various modalities of bariatric surgery which we should be aware about, because that can get the weight down by 30 kg. The problem with bariatric surgery is two. Number one, your fertility has to be postponed by 1 year because you require a huge amount of nutritional support. And with bariatric surgery and sudden weight reduction by 30-40 kg, your AMH levels are going to drop. Because leptin has a role to play in AMH synthesis from the granular cells. And such drop in leptin will obviously have an AMH synthesis. So we commonly advise bariatric surgery for somebody who is obese and low ovarian reserve. But then her AMH is going to come down. So probably we have to think about if the anesthesia is safe, go for your egg retrievals, everything, and then plan the pregnancy later. So when it comes to obesity, PCOS and pregnancy, it is fertility first by ovulation induction or aggressive treatment, and fat second. And it's a nice debate by George Gusinger and Richard Legros, the recent essay which completed. All of you should listen to that debate and really mentions all this very well. Well, thank you so much, all of you. And I'm going to stop here. And any questions and queries, I'll be more than happy to answer.
Thank you, sir. Really, it was a wonderful and eye-opener. And you have actually mentioned very different things. You have shown one study regarding the AMH. I think it is not from India. Like the AMH at the age of 20, it is around, suppose 7.4, it goes to around 4.7 in 40 years age group. But I think I have seen in many patients, the AMH suddenly drops down after 30 years in our Indian population. That is my observation.
Yeah,
What is
madam,
the
actually,
observation, sir?
yeah, you are very right, actually. And let's say in a PCOS lady also, if they're given a PCOS lady beyond the age of 35, the AMH can suddenly drop much more steeper. This is an Iranian study. The Middle
Iranian
Eastern and
studies.
Iranian population is completely different, madam. It's a completely different population. They have much better fertility outcomes than our population. And this decreases could be because PCOS induces a lot of inflammation. And if your PCOS lady has inflamed because of obesity, her primordial follicle depletion will be faster. So even she is a PCOS and could be having a high AMH. By the time she reaches 37, her AMH could have been dropped very drastically. So this inflammation itself is responsible for that depletion of AMH and the follicles.
Okay. And again, there is a AMH variabilities are there in many lab to lab. So we have to rely on the now stimulation.
So I think two things certain. Number one, we have to do AMH with a gold topped vacutainers only. AMH should be done in the local lab, no transport. If you do transport, AMH levels are going to be different. It's a nice study by Richard Fleming on transport of AMH samples and the misreporting. All AMH should be done on Roche technology machine only. No ELISA, nothing has to be used. If you're using these three principles, your AMH will be very, very valuable.
Okay, because it's very unpredictable many times. So you have to rely on the day to
we need to look into the patho lab and what exactly they are doing.
Okay, another one, you mentioned the role of glycogen like peptide 1. That I don't know. I have not used it.
Oh, GLP-1 is phenomenal, madam. GLP-1 agonists are really, it's very common. Semaglutide is so beautiful a drug. I think if you tell more about it, half the crowd in India will start using it. Yeah, its only thing is expensive. But madam, how it works is, it basically, there is something called satiety and there is something called satiation. Satiety means once you have food, how frequently you're going to be hungry again. And satiation means how much food you eat to feel the satiety. So you need to ask this history to the client. Now that becomes a parameter now. And now you introduce GLP-1 agonist. And now you ask the same histories to them. And that is a parameter your GLP-1 is making a difference to them. Obviously, they will reduce it. So GLP-1 agonist is a drug which causes decreased absorption of glucose. There is no gluconeogenesis and there is increased gastric emptying time. Because of this, there is decrease, your glucose level in the body goes down and insulin resistance goes down. Thirdly, there are on the tongue behind your GLP-1 agonist receptors. And those, suppose you're eating sugar after sugar, sugar after sugar. And then those GLP-1 agonist receptors become attenuated. They get tachyphylaxis ho jata hai uska. And then you need to eat more sugar to make yourself happy. The sugar is a kick after all. So GLP-1 agonist will act also on those receptors in the tongue and you will feel happy after eating a small amount of sugary or small amount of carbohydrates. And because of all these things, GLP-1 agonist should be practiced. A huge number of papers on liraglutide and metformin. Simple way to understand a super metformin, madam. So liraglutide, metformin or semaglutide preparations to be given. Give it for 4 or 5 months. No side effects. Patients nicely decrease about 8 kgs, 7-8 kgs. Once they decrease, their morale goes up. Cognitive behavioral therapy becomes, the depression goes away and they feel more trustworthy in you and the system that they will be benefited in future.
Sir, there's a question for you. Sir, few patients don't tolerate semaglutide at all. How you will manage the intolerance?
Yeah, that is true. Then we cannot give semaglutide, obviously. Then I will come to liraglutide. And even if the liraglutide injection is not working onto them, see, it all depends upon your gastric sensitivity. Like some patients even don't tolerate metformin for that matter. Even they will have GI disturbances with simple metformin of 500 or 1000. So these choices just go away from you then. Then you have to go for other choices like your, cognitive behavioral therapy, mindfulness classes. That is more required than the diet and the diet pattern, obviously.
And basically, your this talk was on the how to prevent IVF in young patient, in PCOS patient. But sometimes some patients are very much resistant, and you need higher doses. And you start giving the higher doses, the multiple follicles are coming. So you have to plan IVF only in such patients.
I think Dr. Sharyu is going to address this. Suppose you get high number of follicles of 6 to 8 in a typical stimulation IUI. How would you manage that situation? Not doing an IVF. I think she will handle that thing in a trigger lecture.
Thank you. Anybody?
Thank you so much. Thank you very much.
There's one more question that in a low resource setting, what hormones would you suggest for a PCOS patient?
Okay. Okay. What hormonal test you support? Am I right?
Yes, yes.
Test. Okay, I think if you're doing an ultrasound, number one, an ultrasound is giving an antral follicle count. And if all the antral follicles are less than 4 millimeter, and antral follicle count is beyond 25, and the ovarian volume is beyond 10 centimeter cube, then she is a very bad PCOS. You don't do any hormones and treat simply. I don't mind that. Okay. Now, suppose you are doing and a rosary pattern on the ultrasound. Suppose you are looking at an obese lady. She has a diffuse pattern of antral follicle count. Most of the follicles are 6 millimeter to 9 millimeter. Very few follicles are 4 millimeter or less. That means this is a moderate polycystic ovary, and simple stimulation or weight control will help in this line. So what I'm saying is hormones are not mandatory. Your clinical judgment, you're interviewing the client and her hormonal cycles. Somebody who has cycles every 45 days, it's a simple PCOS. Somebody who has a cycle every 90 days. Somebody who needs to take progesterone to get a cycle, they are bad ones. So if you go clinical parameters, it is very simple to manage PCOS. In case it's a low risk, I really don't know what is the criteria of a low resource setting. But anyway, we are just diagnosing a severe PCOS, which can be diagnosed by history, clinical examination, or ultrasound. Hormones are just an adjunct. So I would obviously do an HbA1c, very important, a thyroid, an associated thyroid disorder, and obviously AMH, FSH, LH if it is permissible in your low resource setting. Androgens generally I don't do, because in India, we are not in Japan or Singapore, where your biochemical hyperandrogenemia does not correspond to clinical hyperandrogenemia. Because in Singapore, even the males do not have beard. So, you'll have to do chemical tests to know whether this is hyperandrogenic. In India, we are clinical hyperandrogenemia itself. So suppose somebody has hair around the areola, between the breast, hair on the xiphisternum to umbilicus, a hair on the back of the thigh. She's a severely hyperandrogenic lady. So in a low resource setting, we can depend on these criteria to go ahead.
Thank you very much.
Thank you so much. Thank you very much for the interest.
Can you go ahead?
Thank you so much, sir.
Riju?
Yes, ma'am.
Is Dr. Shilpi there?
Okay, we'll continue.
Yeah, if Shilpi is there, she can introduce Dr. Manju, or else Sushma ma'am, you can do
Okay, I
that.
will get, because it's my pleasure to introduce Dr. Manju Jila, because I know her since my college days. And I will tell you, she's a really phenomenal lady and very brilliant lady. She was in our unit. I used to see every time with a very big books. Manju is always there, and tremendous power and tremendous enthusiasm to explain. She's a very brilliant lady, and apart from that, I will just introduce her now. The trained transvaginal ultrasound, color Doppler in 1990, trained endoscopic surgery, trained IVF ICSI, University of Alabama, Birmingham, Alabama, USA, and more than 3,000 successful IVF babies. Then achieved the many first in Maharashtra region. She's a really proud of Maharashtra, Marathwada region also. First tested baby, first ICSI baby. Jila Hospital is also training center. So many credits are there with the Dr. Manju. She's a very good player also. We were in the basketball team. Still, we remember we went to AFMC and we are having very fond memories with Dr. Manju. She's a multifaceted personality. So I present to you. So Dr. Manju, the floor is yours. This is stimulation protocols. It's a pleasure to listen the basics from Manju.
Thank you, Sushma. And I really thank Dr. Bindu Chimote for inviting me for this talk. After Sachin Kulkarni, I think I would be a little more, more or less, I wouldn't be able to talk as well as he is, because I think he's a master in this subject. But as far as stimulating polycystic ovaries is concerned, we have been doing it. All of us have been doing it since years, and we've been seeing the changes as research has occurred. And we have been able to make this stimulation more and more patient-friendly and with less complications and better pregnancy outcomes. So the main purpose of any ovarian stimulation in an IVF program is to get the healthy follicles, just as we said, more is not merrier. We want healthy follicles to mature. We do not want a premature LH surge. We do not want ovarian hyperstimulation syndrome. We want high ongoing pregnancy rate, low miscarriage rate, and high live birth rate. So our stimulation should aim at getting the best oocytes out of an ovary. Although that ovary has many, many follicles, we are not interested in those which are not healthy. So the challenges which a PCO patient puts in front of us is that her ovary has too many small follicles of 2 to 9 millimeters. Each ovary may have more than 12 such follicles. She's oligo-ovulatory. Many times periods have not started and we do not know when to start stimulation. She's hyperandrogenic. Majority of these women may have high body mass index, which may want us or tempt us to use higher doses of FSH. And if we use a triggering HCG, they have a very high risk of ovarian hyperstimulation syndrome. Higher doses of FSH may also stimulate many unhealthy follicles, increasing the miscarriage rate and chances of OHSS. And with an agonist trigger, we have to have a very good freezing program in our laboratory in order to give cycle segmentation and equivalent pregnancy rates without OHSS. So what are the protocols that are available to us? The best protocols as on today for a PCOS, we all know, is the antagonist protocol. And in these protocols, usually 3 or 4 things we look at. One is, what is the drug we are going to use to stimulate the follicles? In what dose and how long? Secondly, which medicine or drug are we going to use to prevent the premature LH surge? And what is the dose, or which triggering molecule are we going to use to give the best outcomes when stimulating a PCO ovary? So the antagonist protocol, as we all know, a very standard protocol. In the pre-antagonist era, we were very scared to stimulate a polycystic ovary because we had nothing else than HCG for the trigger. And HCG, we all know, was the main reason for a very severe type of ovarian hyperstimulation syndromes. But soon as we got antagonist in our hands, this problem of ovarian hyperstimulation syndrome almost ended, and people started calling their clinics as OHSS-free clinics, because the entire dictum was to give gonadotrophins from second day of the cycle and add an antagonist, GnRH antagonist, from the 6th day of stimulation, or when the leading follicle became 14 millimeters. This continued for 4 to 5 days. That is, total gonadotrophin stimulation went on for 10 to 12 days, along with the antagonist in the last 5 to 6 days, and then the trigger, depending upon the number of follicles, usually the agonist trigger was given in these antagonist cycles. And agonist triggers prevented ovarian hyperstimulation syndrome to a very, very large extent. Then came the idea that instead of using a large amount of gonadotrophins, why don't we minimally stimulate the ovary? Why don't we use these anti-estrogenic drugs like clomiphene citrate or aromatase inhibitors initially, and then in the remaining 5 or 6 days, add gonadotrophins along with GnRH antagonist, and then give the trigger, so that we may be able to give these patients a fresh cycle and reduce the cost of IVF in these PCOS patients undergoing IVF program. So there are many studies on this. We will discuss that, but this is minimal stimulation. And then came one more drug in 2015. A Chinese researcher said that we can use progesterone instead of the antagonist to prevent the LH surge. We all know we use progesterone in our OC pills, which prevents the production of LH from the pituitary. Progesterone actually reduces the GnRH pulses from the hypothalamus. And so progesterone could be used instead of GnRH antagonist, GnRH antagonist to prevent the LH surge. So these are the major protocols which we are going to discuss today. And we are going to discuss about the follicle stimulating drugs, whether it should be FSH or HMG, what should be the dose, how long should it be given. Then can we have these minimal stimulations? What are the results of minimal stimulation? Can we use progesterone prime stimulation? What is the reason about progesterone prime stimulation? And last, very little, I would be talking about the triggering molecule, because there is somebody who is going to speak on that topic. So now let us know what we should use, whether we should use HMG or FSH while stimulating the follicles in PCOS. We all would feel that these patients have high LH levels. Why should we use HMG? And we also know the background of HMG, that HMG is a 75 IU FSH or 1:1 FSH and LH activity. The LH activity is not coming from LH itself, but from another molecule, that is HMG. We all know that HMG and LH are absolutely similar in their beta chains, but these being glycoproteins, the carbohydrate moieties attached to the beta chain of HMG are many more. They're almost, I think, 6 or 8. And as compared to LH, which is just one carbohydrate moiety attached to it, and the half-life of LH is just around 30 minutes, and that of HCG is around 36 hours. We also know that in our body, the pituitary secretes LH continuously in a pulsatile manner. So ovary is continuously getting LH stimulation. But that does not happen when we give injections from outside once in 24 hours. So we cannot have a drug with LH in it. We need HMG or we need HCG in it. Now, is HCG and LH having the same activity? So these are the molecule, the beta chain of LH and HCG, almost similar, but only one carbohydrate moiety attached to the LH, and about 1, 2, 3, 6 attached to chorionic gonadotrophin, and therefore the longer half-life. But at the molecular level, what is happening? On the theca cell, on the membrane of the theca cell, there is a 7-transmembrane receptor to which the beta chain of either LH or HCG gets attached. But if you see what happens inside the cell, the factors which are stimulated by LH are proliferative and anti-apoptotic, whereas the pathway stimulated by HCG is the steroidogenic pathway. Therefore, HCG acts in a little different way than LH. And so many studies have seen that whether we use recombinant FSH or whatever, ultimately HMG stands a very strong place in giving a live birth in PCOS patients. So these were all the studies which have been taken. As soon as recombinant FSH came into the market, people did a lot of studies between these two drugs, the recombinant FSH, that is Gonal-F, and the urinary highly purified HMG. And all these studies showed that HMG is almost equivalent in its action as the recombinant FSH, and it has almost similar pregnancy rates as the recombinant FSH. But some studies say that it has even better pregnancy rates than recombinant FSH. This study I would like to focus because they have done 620, the Megaset HR study published in Fertility Sterility in 2020, that 620 patients they studied with an AMH more than 5. They used either HMG, that is Menopur, or they used Gonal-F. And what they found is pregnancy rate with HP-HMG was 35% compared to 30% in recombinant FSH. And they also said that the pregnancy loss was only 14%, or miscarriage rate was only 14% in HMG and 25% in recombinant FSH. So one more thing, that recombinant FSH usually increases the progesterone on day of HCG in a much higher percentage of patients as compared to HMG. We know that when FSH is given in higher doses, a different pathway happens where pregnenolone is converted to progesterone instead of androstenedione or testosterone. Now, always it has been said, right from the time we have been using Agonist, HMG, even in the 90s, the earlier paper said, use minimal dose of gonadotrophins. Do not use higher dose of gonadotrophins. And we are always in a dilemma. What should we do for our PCO patients? So a lot of people have come out with, studies and algorithms and charts so that you, especially those who have less experience, can know exactly what should be a starting dose of HMG or FSH or gonadotrophins in any PCOS patient. So this is a nomogram given by a Chinese group where, you put this chart, and once you write the The variables that they have put here are patient's body mass index, basal beta FSH, basal LH, then AMH and AFC. And you can plot this chart according to your patient's values. Now her BMI is suppose 28 and her basal FSH is 3. Her LH is around 8 and her AMH is around 9. AFC is around 25. So the dose that she would require is 125. Of course, we do not get 125. So we start off with 150. But in our day-to-day practice, instead of putting all this, it's always nice, as Dr. Kulkarni said, that look at the type of the ovary. And I feel look at the body mass index and then decide about the dose. Higher the body mass index, a little more will be the gonadotrophin starting dose, and lower the body mass index, lesser would be the dose required to stimulate these patients. Of course, in our practice, we should use a gonadotrophin where the amount of FSH and HMG or LH that they claim should really be available. We are using a lot of urinary products, and maybe really the drug may not be as much as they claim it to be. So using from a good company, good quality HMG would really make a lot of difference in using minimum dosage in patients with PCOS. Similarly, one more chart is available where BMI, AMH, and AFC all are calculated, and some points are put, ovarian sensitivity index is put, and then the gonadotrophin dose per IU is decided. Now, if in an antagonist protocol, we are using only gonadotrophins and an antagonist and a trigger. So let us see certain protocols where we can use anti-estrogens in the initial part of the cycle and then gonadotrophins with antagonist before giving the trigger, so that we can reduce the dose of gonadotrophins, and we can also give milder stimulation, and probably we can do a fresh transfer because they will be at a lesser risk of ovarian hyperstimulation syndrome. So this is a very busy slide. I have just put it into a chart. What they have done is they took, this is a study by, this person's name is difficult for me, but Yahayai. This is a recent study from 2023, from a UK group. And what they did is they randomly took 120 patients, they blinded, and 30 patients in each group, where they used the 4 protocols: mild recombinant FSH protocol, mild HMG protocol, minimal recombinant FSH, and minimal recombinant HMG protocol. The mild recombinant FSH protocol, the women received 150 IU recombinant FSH from day 2 to day of trigger. In the urinary or the mild HMG, they received urinary HMG HP 150 IU from second day to day of trigger. In minimal RFSH and minimal HMG protocols, for the first 5 days, they received 100 milligrams of clomiphene citrate, followed by either RFSH or HMG 150 IU till the day of trigger. In all these patients, they received antagonist as the LH suppressing drug, or LH prevention, surge prevention. And the trigger was either recombinant HCG or agonist, depending upon the number of follicles that were stimulated and the risk of ovarian hyperstimulation syndrome. And so likewise, the transfer was either fresh or frozen. This study is interesting because I think we all can practice minimal stimulation in our day-to-day practice to reduce the cost of the patient stimulation in IVF, especially the PCO patients, because they spend on drugs and then they spend on freezing and thawing cycles also. So what they saw is that the number of gonadotrophins used were very less in the minimal stimulation protocol. They also saw that the rise in progesterone on day of HCG was higher in the minimal FSH protocol. Rest of the parameters were almost same, except the duration of stimulation was higher in the minimal FSH and minimal HMG protocol. And they looked at a lot of parameters, the number of oocytes, the 2PN, the embryos, the blastose, everything, clinical pregnancy rate. But what was the last thing, what was very, very important is that the live birth rate was highest in the minimal HMG group compared to the mild FSH or the minimal FSH group. Again, telling us that probably HMG is doing a better job in stimulating PCO ovaries than recombinant FSH. So this was their conclusion that minimal stimulation with urinary HMG is one of the optimal methods of stimulating PCOS patients as far as getting minimal serum estradiol levels on the day of oocyte maturation trigger, minimal dose of gonadotrophins, optimal number of oocytes, embryos obtained, rate of clinical pregnancy, and the risk of OHSS is also low with minimal stimulation, and we can go for fresh transfers instead of frozen transfers. Now, we have seen clomiphene citrate being used. Can we use letrozole for minimal stimulation? Hello. Can we use letrozole for minimal stimulation? I think a lot more studies are required. Whatever the meta-analysis says is that letrozole does not reduce the requirement of FSH, or it does not increase the pregnancy rate or take-home baby rate, but it definitely reduces the chances of ovarian hyperstimulation syndrome. I personally don't agree with this. I feel we need more studies in Indian population with letrozole, because letrozole has done wonders in PCO patients for ovulation induction and pregnancy rate. Why should it not work in an IVF program? So what this Natalie's meta-analysis said that as on today, the studies do not show, or we are unable to say whether this use of letrozole in high responders reduces the exogenous FSH use, the estradiol levels, or decreases the risk of OHSS. And we need more studies to prove the efficacy of letrozole in mild stimulation protocols. There are certain more studies done by Ahatav Tehrani and others, where they say that it definitely reduces the chances of ovarian hyperstimulation syndrome. In their study, they used GnRH antagonist protocol and recombinant FSH. And in the other group, they used letrozole followed by FSH in the antagonist protocol. And they saw that the chances of, or the incidence of ovarian hyperstimulation was minimal in the letrozole group. One more study, which was done by Liu et al., shows that letrozole improves the follicular output rate in women with high body mass index. So if you use letrozole in patients who are resistant or who have higher body mass index, this may help us to reduce the dose of FSH in these patients. What they did was, of course, this was a progesterone primed stimulation, which they did, not the antagonist protocol. In one arm, they kept medroxyprogesterone acetate with HMG. And in the other arm, they had medroxyprogesterone acetate with HMG with letrozole. And they looked at the follicular output rate, which was higher in the MPA group. And they also saw the implantation rate, which was higher in the MPA letrozole group, but not very statistically significant difference was found. So I feel letrozole will find its place. We have to use this drug a little more in our patients, especially our obese PCO patients who may require higher doses of FSH. And we may use letrozole in the first 5 days, followed by HMG in the next 5 days, along with antagonist protocol. And I feel this would work as good as clomiphene citrate in minimal stimulation of the follicles in PCOS. Now, let us come to the second part, that is the suppression of LH in our PCOS patients. So we knew that the agonist actually downregulated the pituitary GnRH receptors, but the antagonist just temporarily blocks the GnRH receptors in just a few hours. And we have two types of antagonists, citrorelix and ganirelix, but we should understand that the half-life of citrorelix is 20 hours. And sometimes the hyperstimulated patients may still get an LH surge because we give our citrorelix after 24 hours. So sometimes we may have to give it a little faster or earlier than 24 hours, looking at the half-life of citrorelix. And after we stop the drug, the LH activity starts very soon, within a few hours. So here, this is the way we give the antagonist. Gonadotropin started on the second or third day, and the antagonist flexible dose starts when the follicle reaches around 14 millimeters in size, or the fixed protocol is just start on the 6th day of gonadotropin stimulation till the day of trigger, and gonadotropins continue till then. Then we come to progesterone prime stimulation. So progesterone can prevent GnRH pulses by having an inhibitory effect on the hypothalamus. So hypothalamus does not release GnRH, and therefore the pituitary does not release LH. So PCOS became a very popular protocol where we knew that we had to freeze all embryos, or we could not transfer in the same cycle because we know progesterone is going to act on the endometrium and we cannot have a fresh transfer in PCOS patients. But at least we do not have the cost of antagonist injection, and the number of injections that the patient reduces. This was the attraction of a PCOS protocol. But at the same time, we should remember that there are progesterone receptors on the granulosa cells, and the progesterone can have some effect on the granulosa cells and therefore on the health of the oocytes. So various papers after 2015, various papers on PCOS have come. This is how PCOS is given: either fixed dose from the day of gonadotropin, 10 milligram of medroxyprogesterone acetate is given till the day of rupture, or flexible dose like antagonist starts from the 6th day till the day of rupture. So what happened is, in one of the studies by Beguria, he said he did the study on 252 oocyte donors. He used medroxyprogesterone acetate in 87 patients. Of course, they used FSH with ganirelix, and in the other patients, they used simple antagonist protocol. And what they found was that the overall pregnancy rate was unexpectedly low in the recipients of the donors who were stimulated by the PCOS program as compared to the antagonist program. So something is going wrong with the oocytes and the embryos in the PCOS program. So what is this? One more study was showing that in elderly patients above 38 years of age who were undergoing PGD, or for PGTA, they found that in the older patients, the euploidy rate in the patients above 38 years was extremely low. Only 5.4% of the blastocysts were euploid. Rest all were aneuploid. So something was happening to the oocytes in the PCOS program. So then going into the details of how progesterone acts on the oocytes and the granulosa cells, a study was done. And what they found is all these RCTs which compared GnRH antagonist with PCOS, somewhere they have used recombinant FSH to stimulate the ovaries, and in other protocols they have used HMG to stimulate the ovaries. And the comparison was between MPA and antagonist to prevent the LH surge. And in all these studies, what they found is that PCOS protocol produces more embryos and a thicker endometrium with a lower rate of OHSs and equal pregnancy rate and live birth. But this is true only in the subgroup where HMG was used to stimulate the follicles, and not where recombinant FSH was used to stimulate the follicles. So what is at molecular level, what is progesterone doing? This was another study by Long from, again, a Chinese group. And what he highlighted is that progesterone reduced the oocyte yield in a clinic, which can be rescued by higher doses of HMG. Progesterone downregulated follicular growth and consequently reduced the oocyte yield. Progesterone inhibited granulosa cell proliferation via the MAPK and PI3K AKT pathway. And progesterone and FSH coordinated follicular growth while signaling crosstalk on the granulosa cells. In the same study, what they did is they found out that if you go on increasing the dose of HMG in a PCOS protocol, you get similar M2 oocytes after you give 2000 to 2500 IU units for all the 10 days of stimulation. And if you reduce this HMG dose to 1500 or between 1500 to 2000, you still get lesser M2 oocytes in a PCOS program, telling us that we have to use higher doses of HMG when we are using PCOS, even if we are using it for oocyte donors. So now this was about the LH surge prevention, and the last is trigger. We all know that agonist trigger has changed our life. It has removed the problem of OHSS almost completely. But in the earlier part of early 2000s, when agonist trigger was given, patients did not conceive because of the severe luteolysis produced by the agonist. This was, researched and realized that that ugly duckling became a swan. There is a paper on that how this agonist, was called as an ugly duckling, but then it became a swan when you realize that if you give good luteal phase support, you can still use agonist trigger and get similar pregnancy rates. One more important thing that agonist trigger does is it increases FSH surge also along with LH surge. Although this agonist the surge remains only for 24 hours, natural surge remains for 48 hours, and the HCG surge remains almost for 6 days, supporting the corpus luteum for so many days. That is why HCG was one of the best triggers, because of its strong support to the corpus luteum. However, that time we never got an FSH surge, and we still feel that FSH surge also helps in increasing the LH receptors and in separating the cumulus complex from the oocyte wall. And also the luteal function after GnRH agonist trigger can be re-achieved by giving a small dose of 1500 IU of HCG within 48 hours of an agonist trigger. And then we can still go in for a fresh transfer without having any problem of the luteal phase. So to summarize, from all these above studies, antagonist protocol is ideal in PCOS. Follicular stimulation is good with FSH and HMG, but I think HMG gives a little higher live birth rate as compared to FSH. Although FSH gives many oocytes, and many blastocysts and many more to freeze. But it also has a higher miscarriage rate and a lower take-home baby rate, which is our ultimate goal of stimulation in any IVF program. Minimal stimulation with clomiphene citrate and HMG allows fresh transfer and gives equivalent pregnancy rates. PCOS has a place instead of antagonist, but you have to add HMG in higher doses to stimulate the follicles. And agonist trigger prevents OHSS, and luteolysis can be rescued with HCG if a fresh transfer is planned in an IVF cycle of a PCOS patient. Thank you very much, and we are now open to discussion.
Manju, Dr. Manju, it was really classic, and as usual, it's a stimulation class. Wonderful, and you made it everything very clearly, because always there has been a confusion where to add the RFSH or the HMG, and many studies have clearly mentioned there is no such differences there, and you clarified all things. Secondly, there's some studies were saying even if in IVF particularly, when you are using gonadotrophins, you should use a higher doses only. Don't use the lower doses. Sometimes you may not get the proper follicles.
Actually,
and some speakers also mention like this. What's your opinion?
No, that is not the truth. What happens is people think cycle cancellation will be there. if you use lower doses. But remember one thing, that in PCOS ovaries, all the follicles are just, there are no waves. They are all sitting idle just to be pushed by some FSH. Whether you push them slowly or you push them rapidly, it makes no difference. Supposing you start with FSH 150 and you do not get the required response, you may, or HMG 150 and you do not get the required response, you may just increase your gonadotrophins by 75 IU more. I think Dr. Sachin Kulkarni will also be able to comment on this.
That is generally we do like that. We increase, but the studies, few studies, and some speakers last, I think 1 month back, there was a discussion. He was saying that I'll start with a higher dose only. That's why I wanted to clarify. Yeah, please.
Sachin sir, kindly unmute yourself.
Please unmute.
We need to look at two papers published. One is by Haas et al., wherein he looked at the PCOS phenotype and the pregnancy rate in IVF cycle. And he reported that only when, if the phenotype is A or phenotype is B, your pregnancy rates are low. So higher the androgen, the pregnancy rates are low. But when you look at his paper, he has stimulated everybody with 150 IU. And then he has done one cycle of fresh embryo transfer. He uses HCG as a trigger. So that is not a norm of PCOS stimulation in India. And that's why hyperandrogenism or a bad PCOS is making a difference to his study. You look at another study published by Sherry Nichols, and she published a very beautiful study. And she said PCOS phenotype does not make any difference. So what are these phenotypes indicating? They are just telling you that this patient is difficult. So she said give high dose. In her study, she gave a dose of 300 to 450 IU. And irrespective of PCOS phenotype, everybody got 20 oocytes. So I feel, I agree with Dr. Sushma that why are we doing IVF in a PCOS? Is it the PCOS alone? That means the bad PCOS, a high AMH, a high LH, obese PCOS. She definitely requires a high dose. Are we doing IVF in PCOS because of a male factor? Because of some other disease? Well, she may not be a bad PCOS. Then the smaller doses will go ahead. Well, now again, there is a phenomenon called ovarian sensitivity index. So that means how much less gonadotrophins you require to stimulate. So some women could have a low ovarian sensitivity index and they would be chosen. Again, let's not quote the merit megaset engaged trials again and again. You look at the exclusion criteria. Hypothyroid, they excluded. High BMIs, they excluded. They excluded women with AFC beyond 25. AMH was not available then as a test. So when you have all these things, that our real world scenarios are not mentioned in those big trials. So I think going with a higher dose makes sense. And with agonist trigger, more the merrier. That's what I feel.
Thank you so much.
Can I put in my point?
Yes, ma'am.
Yeah, hi. I
Of course, yes.
personally feel that we should not be giving very high doses to our PCOS women. They could be landing up in IVF because now they are like unexplained with PCO. We have made them ovulate with letrozole, with clomiphene, with any other intervention. They have not made it despite ovulation. So what we need to see is their BMI. If they are very high in BMI, maybe we can add 50 units more than the dose what we have decided. Also, my embryologist took out a very large data. The moment oocytes go above 20, we see a lot of immature oocytes and the embryo conversion. Ultimately, the bottom line is what are the utilizable blastocysts we are looking at? What is the cumulative live birth we are looking at? And how many supernumerary embryos will always remain in your cryo tank at the end of 1 or 2 pregnancies, which are very important questions to be addressed. We are still not in the OHSS free clinic when it comes to agonist trigger. There are reported OHSS symptoms
100%.
even after agonist trigger. So my point is that we should see the age, the AMH, the AFC, and the antral follicle count, and then decide the dose, which could be anything between 150, 175. There are very, very few PCO, very few who have this resistant ovary syndrome or polymorphisms who need an HMG or who need a little higher dose. That's my impression for PCO in my practice. My target is to get about 12 to 14 oocytes. That's my target.
I perfectly agree to her. I perfectly agree to her that you really have to quantify your polycystic ovary and look into what is making her bad. If it is a high BMR, a very high AMH, a very high LH, or a previous response for 150 IU of 8-9 doses, nothing has formed. These are the ones who will be going for a higher dose. And somebody who is otherwise has commonly responded to letrozole and clomiphene earlier in an ovulation induction cycle wouldn't need a higher dose. I do agree with that, definitely.
Any questions?
Any
other
questions from any other?
Yeah, we can move to the next
Yeah.
session then.
Thank you so much, respected
My only suggestion to everyone would be, let us all try minimal stimulations in our patients.
Yes, ma'am. Thank you so much, Dr. Manjujila ma'am, Dr. Sachin Kulkarni sir, our chairpersons, Dr. Sushma Deshmukh ma'am, Dr. Shilpi ma'am, for sharing your valuable insights with us today. With this, I would like to move forward to the second session, for which I would like to invite our chairpersons, Dr. Manjushri Bhu ma'am and Dr. Ritu Dargan ma'am. Dr. Manjushri Bhu, she is an acclaimed, hello ma'am.
Hi.
She is an acclaimed fertility and lab specialist from Amravati, Director Indo-German Test Tube Baby Center, recipient of numerous awards, to name a few: Star IMA Amravati Women of the Year Award, Nari Samman Award, and Wonder Foxian Award. Welcome, ma'am. Dr. Ritu Dargan, ma'am, she is a senior consultant and HOD New Era Mother and Child Hospital, Nagpur, and Director Integra Specialty Clinics. She's actively involved in community health projects and A&M trainings. So we are honored to have you both guiding the session, ma'am. Over to you, ma'am.
Thank you so much. And at the outset, would like to thank you, IFS, to give us this opportunity to chair this session. Ritu, can I take over the first one?
Yes, ma'am, please do. Please.
So, like, we have a speaker who is close to us. I recently met her, friend of mine, Dr. Shweta Mittal Gupta from Delhi, and everyone knows her in IFS. She's a big name. She's Secretary Journal of IFS Society, Treasurer IFS, and Convener SIG Reproductive Endocrinology Committee, IFS 2022-24. And she's a recipient of Economic Times Award, Vigyan Vardhan Award. And I really share the stage with Vigyan Vardhan Award. I got last, I think 1995 or 96. Madam has also received the same Dronacharya Award, Icon of Gynecology, Foxy Ethicon Traveling Fellowship. And ma'am is first fellow National Board DNB Reproductive Medicine in India, credited for first pregnancy from Frozen Thaw Cycle, North India, contributed to over 1,000 presentation and publication, teacher to fellows and postgraduate, peer reviewer for assisted reproduction and genetics. And recently she was organizing secretary for a wonderful international conference of Fusion 2024 at Jaipur. Ma'am, all pleasure of mine to introduce you to this August gathering. And her talk is on role of medication adjuvants in PCOS. So let's
Thank
hear
you so
from
much, Dr. Manjushri, and my regards to Dr. Sachin Kulkarni, sir, my teacher in Kolhapur. So, and from Sholapur, I've done my MD from there. And thank you, Dr. Bindu, for coming in. It was such a beautiful presentation from sir and from Dr. Manju. Everything has been covered. There's nothing much to be told. But I will restrict, because Dr. Bindu was very clear that I don't have to talk anything more than the adjuvant. So I'll just share my slide, and I'll be restricting a little practical tips only on the adjuvants. Very beautifully, we have heard everything from Dr. Sachin sir, that what is the pathology. So I've just made it very short. Polycystic ovarian syndrome, and we'll talk about the adjuvants. The incidence, in the women of childbearing age group can be as much as 1 in 10. Worldwide, about 5 to 18% of women are going through PCOS, out of which 20 to 30% will develop diabetes and lipid problems. So when the question was being asked that in the low resource setting, if two tests which really have to be done, then I would say OGTT and I would say a lipid profile, and the third test would be an ultrasound to diagnose that they are PCOS along with the symptomatology, and which Dr. Sachin sir said that if they have clinical signs of hyperandrogenism, then we don't really have to go and investigate hyperandrogenemia unless the hirsutism is so severe that we want to actually find out other causes of hirsutism. 50% of women don't know that they have PCOS and will go undiagnosed. 30% of women with normal body mass index will have maybe lean PCOS. So if you see lean PCOS, do not be mistaken, because the visceral fat is much more, and 70% of women with PCOS have, of course, difficulty, could be having anovulatory infertility. Now, what we're looking at a whole spectrum right from birth till the menopausal age. We are looking at premature adrenarche to adolescent PCO problems, early type 2 diabetes, infertility. We are looking at later, after delivery, cardiovascular disease and endometrial carcinoma, which is very, very important that once they have completed the family, now they need to be in the long-term, vigilance with us. And so they will need a holistically multidisciplinary approach. They will have to go maybe to a cosmetologist, to a reproductive endocrinologist, to a normal endocrinologist, to a cardiologist. So there are so many, and then later on to maybe a gynae oncologist whenever they will have the symptoms. So it will be a holistic approach. Now, how it is leading to infertility? Because it is leading to dysovulation by the time they reach IVF. We could be dealing with poor oocyte qualities. We could be dealing with endometrial receptivities because their endometrium could be hyperplastic. We are looking at poor implantation and early pregnancy losses because of hyperinsulinemia and hyperandrogenemia. And then we are looking at effects of gestational diabetes and hypertension on the fetus. So the basic crux, of course, is hormonal imbalance, and it is because of insulin resistance. So there is no recommendation that you need to go on doing insulin levels. No, you assume that 60 to 70% of patients with PCOS will have insulin resistance, and hyperandrogenism is the crux of the pathophysiology of PCOS, and that is why the androgen excess committee says, other than Rotterdam says 2 out of the 3 criterias, but the Androgen Excess Society says that hyperandrogenism or genemia has to be present to say that she has PCOS. So if we are looking at an algorithm that how do we, go on treating PCOS, so I think we can just see the right-hand side of the slide, and we need to exclude certain differential diagnoses. So we need to rule out a thyroid disorder. Very important differential diagnosis is a late onset adrenal hyperplasia who will present as PCOS. So we need to do a 17 hydroxyprogesterone levels if she has a disproportionately high hirsutism. We need to rule out hyperprolactinemia, and the less, common things, I think, in the differential diagnosis could be other causes of amenorrhea, whether we are dealing with type 1 hypo, or we are dealing with type 3 and any androgen secreting tumors, or Cushing's if she has a Cushingoid features. So androgen excess says hyperandrogenism is most important. And we know that if hyperinsulinemia is the major culprit, then let's start working on that when it comes to algorithm to treat lean PCOS or to treat any PCOS. So the foremost is, I think if I have to talk of any adjuvant, then the first and foremost is lifestyle modification. You cannot go away without it. It has to be. You need a diet consultant. You need a person who can actually get into the exercise mode for them. You need to have a tie-up in your clinic with these people so that you can keep calling these patients, and it gives a positive input to the patient. Otherwise, they never lose weight because they will be in a ping pong phenomena. Then you can think of adding adjuvants. That should I add metformin? What is the role of myo-inositol? how do we treat hirsutism? What can be the different modalities for menstrual dysfunctions? What do we do for acne? And what do we do for infertility? Of course, my talk is not discussing the major drugs for ovulation induction, because I was only asked to talk about different adjuvants. So let's start with, suppose the girl comes with hyperandrogenism. So what are the options? The options are, we have OC pills. We also have anti-androgen containing OC pills, cyproterone acetate, and we have drospirenone. The problem with even cyproterone acetate OC pill is that the risk of DVT is not low as compared to standard OC pills. So you have to take that into consideration, and drospirenone will be a milder anti-androgen as compared to other anti-androgens. The second drug which is very commonly used is spironolactone. You start with 50 milligrams and you can go to 100 milligrams, but you need to give it long term. It does not have the side effect of liver toxicity. Cyproterone is a medication which can help to treat PCOS, reduce testosterone level. The other drug which I would give was finasteride, which was 5 milligram, but that also holds a higher incidence of liver toxicity as compared to spironolactone, which is, I think, the mildest and can be the first line of anti-androgen. And flutamide is absolutely not used in the clinical practice because of high chances of liver toxicity. Now, when it comes to ovulatory dysfunction, OC pills are most commonly given, but I would suggest that we start with progestogen withdrawal bleed. The simple algorithm is that you can make sure that the woman gets more than 8 menstrual cycles in a year, because our aim is to prevent endometrial hyperplasia. But while they are on OC pills or they are on progestogens, of course, they will not be able to get pregnant. Sometimes they can have an unexplained vaginal bleed. The risk of thromboembolism is definitely there. And most important risk is more so in obese women. So always ask history of smoking in girls, document it, and ask family history of thrombosis. And that is what is very important, because we are in the medical legal world and we need to document these two when you are giving the first cycle of OC pills. Progestogens, we are more comfortable. So maybe for withdrawal, they can just have progestogen. But if they are really hyperandrogenic PCO with thin endometrium not responding to progestogen, then we will have to give the lowest dose of estrogen and OC pills to get a withdrawal bleed. Now, what do we do of this hyperinsulinemia, which is contributing 50 to 80% of women who are categorized as PCOS? So we know that insulin binds to the IGF-1 receptors. It will augment the thecal androgen response to LH. It will, on the other hand, inhibit hepatic synthesis of sex hormone binding globulin, more free androgens, inhibition of hepatic synthesis of insulin-like growth factor binding protein. So we must understand that insulin-like growth factor is a more proliferative factor which acts at the ovarian level, and it increases the thecal action, and that is why they have more so problems when it comes to PCOS women. Now, increased levels of testosterone, they in itself reduces the hepatic synthesis of SHBG, which results in a vicious cycle of hyperandrogenism and clinical features corresponding to same. So glucose metabolism in a normal cell is that insulin binds to its receptor to form a complex called insulin receptor substrate. It stimulates the messenger called PI3 kinase. So when we are talking of myoinositols, we will see that how insulin is the primary molecule which acts on the cells for the glucose uptake, and myoinositol is like a second messenger which acts on the PI3 kinase, and the ultimate effect is the same, that they want to initiate glucose uptake by the cell for its metabolism, and they want to reduce the insulin resistance. Now, this IRS, which stimulates PI3, then activates PI3 kinase, which activates GLUT4, which we were hearing in Dr. Sachin Sir's presentation. The glucose is taken up by GLUT4 through the glucose channels for utilizing the energy, and this IRS complex breaks down releasing receptors to go back to its original site. Now, if hyperinsulinemia is the main treatment point in PCOS, then what could be the option? And we will see certain evidence when it comes to usage of metformin, myoinositol, or is it combination of metformin with myoinositol? Some word about N-acetylcysteine. So the treatment strategies is that we know that metformin has a proven efficacy in the treatment of PCOS for a long time. And myoinositol could be a novel insulin sensitizer used to treat infertility in PCOS. Now, if metformin acts as a first messenger, then myoinositol actually is a key messenger to increase glucose uptake, improving insulin sensitivity, and thereby reducing insulin resistance. So what metformin will do, it will initiate the PI3 kinase, the GLUT4, translocation of GLUT4, and basically glucose uptake by the cell. So in simple language, it is helping the glucose move from the periphery into the cell so that it can be metabolized and can reduce. Now, we have heard a lot that metformin before IVF and during IVF and ICSI cycle with PCO can reduce the incidence of ovarian hyperstimulation syndrome. So yes, if you can see the forest plot, the outcome 1:3 incidence of OHSS was the reduction when metformin was given versus placebo or no treatment at all. Now, please remember that this quoted study was in the era when downregulated cycles were being given for IVF stimulations. And now we are in the era where for all our hyper-responders, we are using antagonist cycle with agonist trigger and thus using metformin to reduce the risk of ovarian hyperstimulation does not hold true anymore in the era where we are using agonist as the final trigger. So what does ESHRE 2018 guidelines suggest when it comes to the usage of metformin? That metformin, in addition to lifestyle, you can see it's a level 2 recommendation, could be considered in adolescent with a clear diagnosis of PCO or with symptoms of PCO before the diagnosis is made. So the question that can we use it in adolescent? Yes, we can. Especially if the adolescent girl is trying to lose weight, you know she's hyperinsulinemic. She's not able to lose weight. It will help her transiently to lose some weight and will give a positive impact on the regime, what she's doing. It can offer a greater benefit in high metabolic risk group, including those with diabetes risk factors. So if you see an impaired glucose tolerance test or a high-risk ethnic group, then yes, you can add metformin. But what needs to be taken into, of course, are the GI side effects. Start with lower dose, 500 milligrams, and slowly increase the dose by 1 to 2 milligrams and use an extended release. Metformin use appears safe on long term based on the use in the population. The only thing what it can do is it can lower the vitamin B12 levels, and so supplementation of vitamin B12 may be required on long-term usage of metformin. So ESHRE said it's an off-label usage and health professionals need to inform women and discuss their evidence and possible concerns and side effects. So it is very important that we do. Healthy lifestyle behaviors encompassing healthy eating, of course, and physical activity cannot be overcome. And lifestyle intervention should be recommended with all those with PCOS, excess weight, reduction in waist, central obesity, and insulin resistance. 5 to 10% weight reduction is our goal, and you need to see whether you need to add metformin to achieve this goal or only simple lifestyle management is making them work. So the routine use of metformin before or during ovarian stimulation is not recommended when you are doing an IVF in an antagonist protocol for women with PCOS. So this is the newer thing which we need to get into mind. And I don't use metformin just because I'm scared that a woman will get hyperstimulated, because I'm using a lower dose of gonadotropin, I'm using an antagonist cycle and giving an agonist trigger in hyperresponder. So it will lower the androgen levels by the theca cells, and it will decrease the activity of ovarian cytochrome P450 enzyme. Morley in the Cochrane review found metformin alone compared with placebo may have a higher rate of ovulation, clinical pregnancy and live birth rate, but superiority to clomiphene alone was inconclusive. So if I consider in in PCO women, naturally not doing anything will not give us results. If you only want to give metformin, you can. But if you're looking at ovulation, induction, then adding an oral ovulogen will bring a superior result as compared to only using metformin and waiting for them to ovulate. Though now Eshre says that you can use metformin, but it will have a better result when it comes to menstrual cycle regularization. Doses which we have already discussed. Side effects which we have already discussed, that you start with the lower dose and the maximum you can alone in women with PCOS with anovulatory infertility to improve ovulation, pregnancy, and live birth. Definitely in women with BMI more than 30 kgs per meter square, metformin can be added in CC or letrozole stimulations in an agonist downregulated cycle to prevent OHSS. Now let's have certain 5 or 6 slides on metformin and pregnancy. We know that metformin increases, PCOS women are at an increased risk of pregnancy complications. Let's start from 2011 meta-analysis, which showed that the odds ratio of different pregnancy complication, which increased in PCO as compared to controls. And there was a 3 to 4-fold increase in PIH, preeclampsia, GDM, and 2-fold higher chance for premature delivery among PCOS women. So they said that it is associated with hyperandrogenism, obesity, insulin resistance, and other metabolic abnormalities, which were increasing the obstetric and neonatal complications. Now, what was happening? They have more of placental inflammation, placental thrombosis, infarction during pregnancy, which added to villus immaturity and nucleated fetal red blood cell. There was also alteration, could be because of signs of vascular damage and fetal hypoxia, which could be linked to complications in PCOS. So metformin has been evaluated in several studies in the context of PCOS and pregnancy, and 18.7% incidence of miscarriage in the non-treated PCO women, vis-a-vis 10% in women who received metformin up to 32 weeks of gestation, and there were none in those who received metformin throughout the pregnancy. This was way back in 2008. Then in 2012, the meta-analysis showed that out of 7 studies analyzed, metformin reduced the development of GDM in pregnant women with PCOS. As the methodologies were different and there were no RCTs at that time, so these results were inconclusive. The biggest and more accurate RCT regarding this issue was performed by Vanke et al., and they showed no effect of metformin on the prevalence of GDM and preeclampsia, and only a significant reduction in preterm delivery in a subgroup of compliant patients in the per protocol analysis. A second RCT in 2019, they reported reduction in risk of late miscarriages and preterm birth, but no difference in the prevalence of GDM. The effect of metformin on preterm delivery are of notable interest given the known association of preterm delivery with neonatal mortality, respiratory distress syndrome, cerebral palsy, GI, cardiovascular effects, disorders, retinopathy of prematurity, and high costs related to prenatal care. So metformin was able to normalize androgen levels and insulin levels during pregnancy, and they could reduce the AMH levels, an ovarian marker associated with a higher risk of PCOS in the female offspring as early as 2 months of life. And the study in the Norwegian children born to women with PCOS receiving 2 grams of metformin daily from the first trimester to delivery showed that women who use metformin in pregnancy lost less weight and their infants were heavier than those in the placebo group after 1 year postpartum. So possibly this was not getting affected. Now just moving on to myoinositol, where phosphatidylinositol is the key messenger. We need production and activation of PI3, which we saw in the earlier, flow chart for normal cells to metabolize glucose metabolism, and inositol reduces Analytically, both it produces and activates PI3 kinase, can act as a precursor for PI3 kinase. Logical function that it will mediate glucose uptake and the FSH signaling, whereas dichloroinositol will ameliorate insulin-induced androgen synthesis, and that is how 2:4 combination has been suggested. The dose is 2 grams daily, and there is some data, though not a very large data. So what about metformin and myo-inositol? They have been used as insulin sensitizers to correct the biochemical parameters, insulin resistance, hormonal parameters, lipid, leading to betterment of menstrual irregularity, hyperandrogenism, and infertility. Now, since myo-inositol and metformin have a different mechanism of action, so the groups who are proposing myo-inositol, they say that they both can work in combination and can have an additive effect in the management of hyperinsulinemia. So this is the inositol levels in PCOS girl as compared to normal women, which were supposed to be considered higher. If you can see the yellow bar. So this were the inositol levels. This was an RCT which was comparing myo-inositol to metformin, and the women who were included were PCO, oligomenorrhea, amenorrhea, with or without hyperandrogenism. And of course, most of these tests, any history of chemotherapy or radiotherapy, myo-inositol was given 1 gram per day in group A, and B received, which is metformin 1000 and myo-inositol 1 gram. The primary outcome measure in only myo-inositol group showed an improvement in menstrual irregularity by 66%, and fertility improved by 57%. In metformin group, menstrual complaints were improved in 15%, and fertile, of course, this was a very low number of patients. But when they gave, both the drugs together, they found that menstrual irregularity was corrected in all the 8 patients conceived. But if you can see, was very slim. We don't have larger studies when it comes to myo-inositol. These were the secondary outcomes in all the 3 groups, and you can see significant when it came to BMI reduction in the myo-inositol group, in the metformin group, and in the group who received both.
Have we lost
I
connection?
think she has lost connection.
Yeah.
Yes.
Maybe
Maybe
just call her up. Yeah.
maybe we can wait for some few seconds or minute till you connect her. So it was a great presentation, evidence-based, with many RCTs which are suggesting that metformin do have a metformin do have a intranatal and postnatal problems to baby, maybe RDS and many other problems. So I hope Madam comes back for other adjuncts so that we can get a highlight on other adjuncts also. Because this is such a risky topic, not exactly risky, but meri marji. Many people, they use at metformin, many use myo-inositol, many say, but I think the crux of PCOS management is a lifestyle modification.
Dr. Shweta has joined.
Yeah, that's great. That's great.
I think I can just go to the last part of my slides and then we can just have a little discussion.
Yeah.
I'm so sorry I got logged out. So we were just discussing that. So coming to just the end of my presentation. So the bottom line was that combining myo-inositol and metformin can have a better control, possibly on glycemic control or lipid profiles and expression, which are related to insulin and lipid metabolism. One word about dexamethasone as an adjuvant, I personally don't prefer. The mode of action can be that it affects the GnRH pulsatility and increases FSH release. The recommended dose is 2 milligrams from day 2, day 3 of the menstrual cycle for 10 days, along with maybe clomiphene or letrozole for 5 days. And this showed that it had a better results in CC resistant cases. So you can use it with clomiphene or letrozole, but in resistant cases. And this was a retrospective analysis of 42 this study. Dexamethasone 0.5 milligram were added for 7 days with letrozole 7.5 grams additionally, and they saw better results. But personally, I am little skeptical when it comes to usage of steroids. Again, I'm skeptical when it comes to usage of N-acetylcysteine as a standalone insulin sensitizer agent. This was one of the recent systemic review and meta-analysis of an RCT, which I found 910 women with PCOS who were given N-acetylcysteine or placebo. They were high risk of selection, performance, attrition bias in both the studies, and high risk of reporting bias in 4 studies. So the bottom line was that it showed significant improvement in pregnancy and ovulation as compared to placebo, but they were less likely to have pregnancy or ovulation as compared to metformin. So I would say if we have to use one adjuvant, then that adjuvant has to be metformin. And when it comes to vitamin D, a lot of prescription has been given, though it will not directly improve the ovulation rate. Theoretically, insulin resistance is directly related to vitamin D, one of the most distinctive characteristic of PCO phenotype. In this study, it was suggested that vitamin D therapy may help PCOS women with their insulin sensitivity. And in addition to insulin resistance, cardiovascular issues are a second metabolic disturbance that PCOS patient with low vitamin D levels can experience. And vitamin D supplementation maybe will improve menstrual periods, increase follicular genesis, and decrease blood testosterone levels in PCOS women. So I think to sum up, I think hyperinsulinemia, if it's the mainstay in the pathophysiology, the main diagnostic criteria in PCOS is hyperandrogenism, hyperinsulinemia, and ovulatory dysfunction. I think metformin is my first insulin sensitizer or an adjuvant. Synergistic action of myoinositol with metformin may result in significant reduction in the drug dosage, of course, not the cost of efficacy. And the combination of these two drugs can work synergistically and give more metabolic and reproductive benefits as compared to single drug works alone. When it comes to ovulation induction, I think we need to resort to letrozole as the first line and metformin as an adjuvant. Thank you so much for patient hearing.
Thank you so much. It was a really evidence-based and excellent talk with so many RCTs and presenting herself so well. Thank you so much, Dr. Shweta. And your carry home message is very best and perfect in the sense that you use metformin lifestyle modification and a combination of myoinositol with metformin, vitamin D as a supplement just to improve the overall health and to avoid the cardiovascular risk. Definitely other adjuvants you have not touched upon because they really have no evidence-based treatment modalities on different research platform which is seen. Thank you so much. Now I carry on. Any questions or maybe we can take at the end? I may invite Dr. Ritu to please carry forward. Dr. Ritu Dargan, please.
Yes, ma'am. Thank you, ma'am. Can we have Dr. Sharayu's CV, please? Yeah. So our next speaker we have with us is Dr. Sharayu Mohite, and she will be speaking on a very important topic, the final trigger, when and how. So Dr. Sharayu is a fertility consultant at Jahangir IVF Pune and Nova Solitaire Care at Pune. She is a fellow in reproductive medicine under Dr. Sachin Kulkarni. and has done her diploma in reproductive medicine at IBC Dubai and has secured a first rank with distinction and has been an international faculty for many IVF courses at Dubai. So Dr. Sharayu, I welcome you and request you to please start your presentation.
Yeah, at the outset, I just want to thank Indian Fertility Society and Vidarbh chapter for giving this opportunity to contribute to this PCOS awareness webinar. And thank you for the topic which you had given to me about the trigger. So I'll just share my screen. I'm not able to share my screen. Can you just allow me or make me host?
Just a second.
Now you should be able to share. I have made you a co-host.
Yeah, I'll just check that.
Yeah.
Still not able to actually.
No?
No.
Mr. Sayan, can you stop sharing your slides if at all you're sharing?
I'm sharing from my end, ma'am. I have stopped sharing. So
Okay. Now can you share?
No, I'm not able to share my screen. 1 minute.
Now?
Yeah, I just check once.
I've made you the host now. So
Still not. Are you able to see? Not, no?
we
No,
can
it's
see
not
the
with- not
screen, but
visible.
not PPT.
It's
Yeah.
a blank screen.
Yeah.
have you opened your PPT and then trying to share?
No. Actually, I'm
open
not able to share my screen only. Means
Okay.
desktop, yeah. Not me, right?
Ma'am, can you close it once and then reshare it? Try resharing.
Yeah, I have just done that. No, I'm not getting that option of sharing my screen actually.
The share screen option is available now down.
Yeah, that is there, but I'm just able to some video.
So are you getting screens, documents, advanced, something accordingly?
Yeah, I'm getting basic, advanced, and files, but in basic it is only whiteboard. It is virtual background in advanced, and files I'm not
So
able.
have you opened your PPT?
Not yet.
No, so do that. First, open the PPT and then go into this and share. Open the first slide. I mean, open your PPT and put it on the first slide. No?
No. What I'll do, I'll just share my presentation, but no, I'm not able to do that.
No, so have you opened your PPT?
Yeah, I have opened. Actually, I'm using
So
MacBooks. I'm not sure that whether that is a problem.
you open your PPT, keep it on the first slide, and then keep parallel windows. I mean, don't minimize or close any window. Let it be open and now start sharing. And when you get the screen option, just click on the screen. So you'll get the PPT there.
That screen option is only not coming, ma'am. That
Oh.
is the problem, yeah, actually.
Okay.
Mhm.
Now, yes, we got it.
Yeah, okay. I'm so sorry for this technical problem. Yeah. So, about what is the timing of the trigger, when, what, and how. So, we all aware about few things about the physiology of the trigger and let me just. So we'll just go quickly about the endocrine profile, and we all aware that we'll be using agonist trigger, either HCG trigger alone, or dual or double trigger. So what points we are going to see, whether it's a measurable, reliable, whether the triggers is safe, and the clinical outcome. So we are very well versed about this slide. So if you see that how in clinically the natural surge happens and the ovulation takes place, that first 14 hours there is LH surge, next 14 hours it is LH plateau, and then in next within 48 hours it comes to a baseline. So this is how the natural physiological trigger works. In case of HCG trigger, initially the progesterone level, the HCG is having 7 times LH-like activity, and this HCG will take this LH-like activity very high within in next 6 to 8 hours, and that will keep high for next 6 to 7 days. And that is why when we give HCG trigger, it is a long-acting trigger and it supports the luteal phase in initial 6 to 7 days. When it comes to GnRH agonist trigger, the LH-like activity will be there, there will be LH peak in next 4 hours, but within next 20 hours, it will come to baseline. So within 24 hours, the GnRH agonist action will come to baseline, and that will lead to crash luteolysis. When it comes to kisspeptin, it is not still in market, and the kisspeptin 2 hours is peak and 12 hours is the baseline. So basically, we'll be just focusing, we all aware that how the LH surge happens, that whenever the E2 level is more than 200 picogram for 50 hours, the LH surge starts, and then there is a LH peak. And in natural physiological trigger, there is FSH rise along with LH peak, and then the LH plateau comes, and then the natural trigger works and the ovulation happens. In HCG, it is a long-acting trigger, and in agonist, it is short-acting trigger. So what is more important, that amplitude of LH rise decides the maturation and ovulation. So for maturation, it is 5% of LH rise is necessary. So when the LH crosses 15 to 17 MIU, the follicle maturation has been takes place, that is from meiosis 1 to meiosis 2. But there should be 85% of LH rise should be there for ovulation to happen. So duration of LH completes the luteinization of all granular cells to lutein cells, and it decides the adequacy of luteal phase. So in this picture also, it is depicting the same, that HCG is longer acting, but agonist trigger is shorter acting. And this is a very beautiful paper, which is explaining about the physiology and the novel concepts of inducing this final oocyte maturation in IVF. So we always talk about nuclear maturation of the follicle and how the LH surge takes place, and getting that meiosis completed. But we should focus also on the cytoplasmic maturation. So cytoplasmic maturation is nothing but the arrangement of mitochondria, endoplasmic reticulum, and this along with metaphase 2, completing meiosis, the cytoplasmic maturation also has to be completed to make the oocyte competence. So what is important for this cytoplasmic maturation is mid-cycle FSH surge along with LH surge. So LH surge is important for oocyte maturation, but FSH surge increases that LH receptor on the granular cells, and it completes the cytoplasmic maturation. So what the action of FSH is, it tightens the gap junction and pours, it actually pours the nutrition to the cumulus oocyte complex. So that is why even in natural physiological trial, as I was mentioning, there is FSH need. In a same way, the FSH surge is very important for cytoplasmic maturation. And we all aware that in agonist trigger, there is FSH need, but in HCG trigger, there is no FSH. Now, when it comes to trigger, when it in ovulation induction, either in PCOS or in patients with unexplained infertility, the ovulation induction agents we use like clomiphene citrate, letrozole, gonadotropin, and then we'll talk about IUI cycle trigger decision. There is no literature published regarding trigger criteria in ovulation induction with ovulation induction agents. And there are conflicting results in regards to optimal size of the lead follicle at the trigger and pregnancy outcome in IUI cycle. Basically, it depends on the situation and age and number of follicles are developed. Now, when we were talking about in physiology, once the follicle is recruited and there is a dominant follicle which is secreting the estradiol level beyond 200 picogram and is lasting for 50 hours, then LH surge will start. But when we have stimulated or we are doing control ovarian hyperstimulation and there are more than 2 leading follicles are present, then better to trigger when the follicles become more than 16 millimeter. Because these two follicles or more than these two follicles are going to collectively secrete more amount of E2 and there will be early LH surge. So before the innate LH surge takes place in that particular cycle, we should give our trigger. So in patients who are young age with normal menstrual cycle, once the lead follicle is more than 17 millimeter and the desired endometrial thickness is there, then we can go ahead with trigger. But if the less endometrial thickness is there, then we can wait the follicle till become 19 to 20 millimeter and then we can trigger irrespective of endometrial thickness. Obviously, in patients when there is advanced age or lower end reserve, they will be having short cycle and they will be having gonadotropin surge attenuating factor deficiency. So they will have their innate LH surge quite early, and that in those patients, better to trigger once the lead follicle is more than 16 millimeter before she has her innate LH surge. If the endometrium on the trigger day is on the thinner side, then evaluate the endometrium in mid-luteal phase after 7 days of your trigger. And if it is more than 7 millimeter, don't label that patient that she is a thin endometrium, and no need to concern about that if she is having a good endometrial thickness in mid-luteal phase. Now, decision making for IUI. This was a very nice study was been published by Chen et al. About letrozole HMG cycle, and he discussed about optimum follicle size at the HCG trigger with or without LH surge. So this was the particular paper where they had given letrozole HMG as stimulation protocol for IUI cycle. Almost 3,797 IUI cycle been studied, and they divided into two groups. One group is where the LH surge has not taken place, LH less than 17, that is HCG group, and another group where the IUI or stimulation protocol with letrozole HMG, but there is no there is spontaneous LH surge where LH is more than 15 already. So they didn't cancel the IUI. When the LH surge is already taken place in such IUI cycles, they had done IUI within next 24 hours. And they analyzed result. The first group was HCG trigger group, and they divided into follicle of 16 to 18, 18 to 20, and 20 to 22 MI. 20 to 22 millimeter of the follicle. And if you look carefully, the better clinical pregnancy rate was when the lead follicle was between 16 to 18 millimeter. So when you catch follicle younger, then the live birth rate, the ongoing pregnancy rate were better compared to when the follicle has already crossed 20 to 22 millimeter. So catch the follicle younger. That is what this message is we are getting from this slide. Now, when they have studied in patients who had already LH surge, there is spontaneous LH surge in IUI cycle, and they have done IUI within next 24 hours. In those patients, the pregnancy rate with 14 to 16 millimeter follicles significantly higher compared to 20 to 22 millimeter. And in spontaneous LH surge group, no need to cancel the IUI cycle, even if there is a small size of the follicle is there. And patients with 2 lead follicles were 2.5 times having more chance of clinical pregnancy than single lead follicle. To summarize this complete paper, whenever we have a follicle, when we are doing letrozole HMG cycle and we have more than 2 or equal to 2 follicles, in those patients, catch the follicle younger. And even if she has already a spontaneous LH surge, don't cancel the IUI. You can go for IUI in next 24 hours, irrespective of the size of the follicle. The pregnancy rate is not going to change. Then a very common question at the time of trigger, if the endometrium is thin, whether to cancel the IUI or to go ahead with supplementation like exogenous estrogen and all. So there was a very beautiful study published by Weiss et al. That how thick is too thin in patients with IUI cycle. So when we do ovarian stimulation with gonadotropin alone, the results in thicker endometrium than obviously with clomiphene citrate and letrozole because of more number of follicle recruitment. Combination of clomiphene citrate with gonadotropins will be still having a thinner endometrial thickness compared to letrozole. Cancelling IUI cycle with thin endometrium because of the presumed negative effect of thin endometrial thickness doesn't have any proof. So why a thin endometrium is clinically more relevant in IVF cycle than in IUI cycle? Because in IVF cycle, we are given many number of gonadotropins and more follicles are recruited. So thin endometrium with maximal ovarian stimulation condition implies genuine diminished implantation potential compared to a thin in milder stimulation conditions as with IUI. There we are giving stimulation for 9 to 11 days. So, with all these things, more number of follicle recruitment, if still the endometrial thickness on the day of trigger is high, then definitely we are looking at the thin endometrium. But that is not in case where we have milder stimulation protocol in patients with IUI. And embryos developing in vivo are less susceptible to this higher oxygen exposure compared to embryos developing in vitro. And thus, in IUI ovarian stimulation, the endometrial thickness doesn't matter. So if you are anxious that on the day of trigger, the endometrial thickness on the lower side, just call her on after 7 days of the trigger and see if she is having a good endometrial thickness, then no need of worrying. You can just no role of going for exogenous estrogen supplementation also, because it is not going to make any difference to that endometrial thickness. Then about HCG trigger, as Dr. Manju ma'am was explaining that HCG is having LH-like activity. It acts on LH receptor. It binds to LH receptor, which is immobile, while LH binds to LH receptor, which is rotationally mobile. And hence, they have different receptor activation. HCG is having 5-fold higher affinity to LH receptor than LH itself. And it has more sterogenate cyclic AMP pathway, which supports early pregnancy. And LH is having anti-apoptotic ERK1 and ERK pathway. So it causes oocyte maturation. So when it comes to about what doses of HCG we should do, they have done a study that after 24 hours, they have analyzed that how much is the rise in the HCG. So 5,000 IU HCG was given, it was 113 MIU, 10,000 to 229 MIU, and 15,361 MIU. And the study mentioned that oocyte yield did not decrease beyond 5,000 IU dose. So 5,000 IU HCG is good enough to give for a trigger in patients with IUI or ovulation induction, or when we are planning our IVF trigger also. Then which preparations to be used, whether to use RHCG or urinary HCG. So there is no difference when it comes to RHCG or urinary HCG. I actually purposely removed the slides for the evidences where they have compared RHCG versus urinary HCG, and it doesn't make any difference in relation to oocyte maturation, implantation rate, clinical pregnancy rate, or live birth rate. When HCG trigger can fail, if we look at the literature, the incidence of trigger failure in HCG is less than 1 or 2%. It is not higher. And in which patients it can fail? In patients who are having very high BMI, where the dose is given only subcutaneously and not deep intramuscular, and we have used route as subcutaneous. So in this particular paper, they have mentioned that when we have an intramuscular dose of HCG, then the HCG level is higher in obese patient compared to if we are giving it subcutaneously. So when we are giving it intramuscularly HCG, use 3.5 centimeter needle, lateral quadrant, deep intramuscularly if you give, then the absorption is better. Sometimes it just goes below the skin or subcutaneously, where the trigger may fail even if you are given the adequate dose. If you are giving this recombinant HCG, that is Ovitril, in that case, instead of 250 microgram, you can give it 500 microgram. So the trigger won't fail when you are giving HCG. Then we all aware about HCG and OHSS, and previously when the Agonist cycle and HCG was the only trigger which has been used, everybody had dealt with OHSS. So HCG stimulates corpus luteum for long periods and increases OHSS. I'm not going to go into detail of the physiology. We all know that there is increase in VHF and angiogenic activity, and that will cause. So that is the drawback of HCG trigger. Whether the HCG trigger is measurable, it is measurable, but it is not a common practice. So initially, when used to give HCG trigger in patient who are for antagonist protocol or stimulation cycle, when we are giving HCG trigger on the day of ovum pickup, we used to do urine pregnancy test and just to cross check that whether the HCG trigger has worked or not. But that was in old days. Now we are not doing, because HCG triggers very well if you are given it in a proper way. It is a reliable trigger, definitely, and there is no comparison available till last decade. Safe, obviously no in patient with OHSS, in patient with PCOS, or patient who are high responder, or where there are we are expecting more than 15 follicles on the day of trigger, then definitely it is not a safe trigger at all. Clinical outcome, yes, good, since all of us have enjoyed the pregnancy for a few decades and there is no comparison available and no comparative studies are also available. Now, when it comes to PCOS, obviously the most fearable iatrogenic complication which we all fear of is OHSS, and agonist trigger is boon in that. And as Dr. Manju ma'am was telling, that the ugly duckling story. So very beautifully that paper has actually mentioned that how the agonist trigger initially was been outcasted, and now how the agonist trigger is actually a physiological trigger because it has a advantage of giving that FSH need, which is very important for cytoplasmic maturation or tightening the gap junction to make the oocyte more competent. So what all agonist trigger available? Leupride, that is 3 milligram, decapeptyl 0.2 milligram, buserelin, and naferilin, that is nasal, which is not available in India. But leupride and decapeptyl is what we are using as agonist trigger in our routine practice. What is the drawback of agonist trigger? Though it is a physiological trigger, in 4 hours, the LH will be peak and then it will go down in next 20 hours. So in 24 hours, the action will be completed. So rapid fall in LH level in 14 to 20 hours after agonist trigger induces active luteolysis. Agonist trigger with fresh embryo transfer, there is obviously low pregnancy rate and increased early miscarriage. So Kolibiansky and Humaydan, these are the two authors who started giving agonist trigger and doing fresh embryo transfer. And what was the result? That with GnRH agonist trigger in anticycle, when they have done fresh embryo transfer, the clinical pregnancy rate was less than 5% and there were high miscarriages rate. So they actually abandoned the study and stopped doing fresh embryo transfer, and they just discussed that this is not going to work because the pregnancy rate is very, very low. Later on, both these authors met in one conferences and they discussed that though it is not giving a good result in fresh embryo transfer, it has very high success rate when it comes to frozen embryo transfer with supernumerary embryos. The oocyte competence was good and it has better than frozen embryo transfer after HCG trigger. So because the FSH nick is there and that advantage is there. So when they discuss all these things, then they tried to do a fresh embryo transfer with intensive luteal phase support. So poor reproductive outcome was not because of defect in the follicle maturation, but it was or impairment of the embryo. It is mainly because of the crash luteolysis which was there after giving GnRH agonist trigger. So in contrast, it was caused by low LH level resulting in low progesterone value to support the luteal phase. So what they have done, Humaydan et al., he had done in intensified luteal phase support in another way, where small HCG dose of 1500 IU was given on the day of oocyte retrieval and again on the day 5 days later of oocyte retrieval. And Engelman had done intensified luteal phase support, not adding HCG, but giving injection progesterone intramuscularly and estradiol continuously in intensified luteal phase support. And when they studied this with fresh embryo transfer with agonist trigger, the clinical pregnancy rate increased and was better than 5%, which they had last time, and it went up to 30 to 35%. So agonist alone, no in IUI cycle due to luteolysis, you will induce earlier periods as well. So typically the lady will be having history that when you give agonist trigger, she will be having menses within next 7 days. Only with multiple but less than 4 follicles, if agonist trigger, then you can give intensified luteal phase. But as soon as there is HCG component, it may again leads to OHSS. Intensified luteal phase in IUI is not defined. That whatever the paper talk about, Peter Humaydan and Kolibiansky, Engman, these were all about in IVF cycle. But there are no studies which define intensified luteal phase support in IUI cycle. So, we all aware that agonist trigger can fail, and that there are 4 to 5% chances that agonist trigger can fail, and we may land up into empty follicular syndrome. So it's very important in our routine practice, we measure whenever we are giving a PCOS patient or high responder patient agonist trigger. So as we are aware that in next 4 hours, it will go up, the LH will go up and it will start coming down. But look at the progesterone curve. The progesterone start rising and then progesterone will keep high when the LH is coming down. When we are measuring the trigger, when we are giving agonist, in that case, after 4 hours, generally our trigger goes at night. So it's very difficult to keep patient admitted and do LH level after 4 hours. So we do this measure the trigger after 12 hours where the LH has started coming down, but the progesterone is on the higher side. So is agonist trigger reliable, or it can fail? Yeah, it can fail in 6 to 7% of the cases. When we can say that trigger has failed, when you are post 12 hours of agonist trigger, when the LH is less than 15 and progesterone is less than 5 nanogram, then the trigger has not worked. And it's very important step, because if you don't measure the trigger and you go ahead with oocyte retrieval and you land up with very less metaphase 2 or empty follicular syndrome, maybe the trigger has not worked, and that is why you are actually facing this problem. So empty follicle syndrome and or less oocyte yield. In which patient we expect suboptimal oocyte yield? Patient who are having low or high BMI, or when you have started your IVF stimulation with very low basal LH level, like you are given pretreatment with antagonist, or she has received antagonist injection subsequently, which has taken her LH down. In that case, you can have a suboptimal oocyte yield. Start day LH level less than 1.2, low trigger day LH, and prolonged stimulation, high FSH dosing. Long COCs also will decrease LH on the starting day of stimulation. And patients who are having hypogonadotropic hypogonadism, in those patients, there can be suboptimal oocyte yield. Here I'll just mention there could be a PCOS lady who is hypo. And now the question is, in PCOS with hypo,
I request others to kindly mute themselves.
So in patient with PCOS who is having hypokypho, it's better to do gonadotropin agonist stimulation test to see whether the agonist trigger is going to work if she is a PCOS. Otherwise, if we give HC trigger when she is having multiple follicle recruitment, then she may land into OHSS. So even if the patient is PCOS, it's better to have their basal FSH and LH value. Empty follicle syndrome could be because of inadequate LH trigger. Immature oocytes have dense cumulus, hence difficult to retrieve. False empty follicle syndrome could be error in trigger dosing, 2/3 of cases can be like this. Genuine empty follicular syndrome is a very, very rare scenario where hormonal response is detected, but oocytes are still not mature. The HCG or LH value where you still have EFS is still not defined. Now, definitely not in patients who are having PCOS, because now all of us are moved to antagonist cycle and we are doing segmentation where we are giving agonist trigger, freezing the embryos, and then we are doing frozen embryo transfer. But when, just to complete this topic of trigger, there could be a scenario where, dual or double trigger can be given. So in patients who are having normal response or poor response, dual trigger is simultaneous use of agonist and HCG trigger. And double trigger is consecutive use of both the triggers. So giving GnRH agonist at 40 hours and giving HCG at 36 hours. So dual trigger, Ding et al. In 2017 meta-analysis, dual trigger or HCG trigger, they have studied in 527 women. No difference in oocyte number, maturation, fertilization rate, but pregnancy rate was more in gonadotropin HCG combined group. Relative risk of 1.55 and this interval between 1.17 to 2.06. Double trigger, Sacher et al. In 2008, GnRH agonist trigger at 40 hours and HCG triggers at 34 hours. HCG group had 7.9 oocyte and GnRH group was having 9.9 oocyte. Empty follicular syndrome, 0.9% in HCG and 2.9% in GnRH trigger. So ongoing pregnancy rate, 23% in HCG group and 26% in double trigger. But double trigger is a phenomenon of retrospective, where in cycle you have landed up with less oocyte. It is not a usual story. What should be the follicle size at the time of trigger? Small follicle and large follicle have less oocyte yield. More than 3 follicle of more than 17 to 18 millimeter, that we can decide how
Can you
trigger
please
criteria.
mute yourself, please? Jayashri, Dr. Jayashri, can you mute yourself, please? Yeah, please continue. Sorry,
Yeah,
Doctor.
no. A follicle size at the time of trigger, small follicles and large follicle may have less oocyte yield. More than 3 follicles of more than 17 to 18 millimeter, or when this was the criteria borrowed from agonist trigger. But when we are practicing agonist trigger and when we are starting with asynchrony, when the maximum number of follicles in that herd is more than 17 millimeter, then we will decide to go for trigger. Dubey et al., the 16 to 20 millimeter follicle were having better fertilization rate, almost around 69.9%, and between 20 to 26 millimeter fertilization rate was 73.9%. So anywhere between 16 to 22 millimeter have the best maturation and fertilization rate, and then we can decide our trigger in that particular time. Now, many of us are using actually PPOS even in patients with normal responder or in patient with PCOS. So one has to remember that this particular paper have beautifully explained that there is a delayed ovulation of PPOS stimulation because in PPOS, the progesterone down-regulates this LH-CGR receptor quite it is completely suppressed in pituitary. So the hypothalamus pituitary ovarian axis takes times to recover in compared to in antagonist cycle when we are giving trigger. So PPOS inhibit LH level and LH-CGR expression on pre-ovulatory follicle before the trigger. Progesterone synthesis and progesterone receptor expression reduce within 4 to 6 hours after HCG. The ovulatory genes regulated by progesterone receptors are down-regulated in PPOS, and this delays ovulation at 12.5 hours after the trigger. So PPOS has delayed follicle wall degradation, VEGF, protease, cumulus expansion, all is affected when you are using PPOS protocol. So when you are doing PPOS protocol, ovum pickup to trigger time delays, like as we do our pickup at 35 hours, delay by 1.5 to 2 hours because it has better outcome in comparison with mature oocytes than at 35 hours. So when you are practicing PPOS, delay your ovum pickup timing. PPOS inhibits LH levels badly before trigger, and that is why it delays the ovulation. Now, when we are taking patients with PCOS or high responder for IUI, and when we do gonadotropin IUI cycle, there could be a scenario where you have multiple follicles. You have a follicle or 3 or 4, and being PCOS, you don't want to take chance of giving HCG trigger, and it's very difficult to tell the client that you have received so many of gonadotropins and now let's cancel the cycle. But we all fear about OHS. Then how we can still go ahead with continuation of the cycle and still have a good result is by giving GnRH trigger in IUI cycle. So agonist trigger in IUI cycle failure, there can, if you add HCG for intensified luteal phase, there is a small risk of OHSs. Intensive luteal support, obviously, like if you give for HCG, it will add on that, and high dose of progesterone and estradiol is required. So instead of doing all these things and taking risk of OHSs by giving HCG trigger, we can go for modified luteal trigger. So this is a proof of concept of study which we are doing, and we are almost done now. 28 to 30 cases of this modified luteal trigger. When we have more than 3 follicles which is recruited, now the option is to cancel the cycle or go ahead with cycle because of risk of OHSs. In those cases, we are giving GnRH trigger in modified way. So crash luteolysis may decrease the chance of pregnancy and no sustainable level of LH will be available. And then how we can divide this agonist trigger? So 12 hourly 3 doses of this agonist trigger can be given. So we use lupride as our agonist trigger. So when we have more than 3 follicles of more than 17 millimeter, we divide this 4 ml into 1.5, 1.5 and 1 ml. Let's say I had started giving trigger today at 8 o'clock, tomorrow morning 8 o'clock, today at 8 o'clock in the evening, she will receive 1.5 ml. Tomorrow again at 8 o'clock, she will receive remaining 1.5 ml. And tomorrow evening again, she will receive 1 ml. So every 12 hourly, you are giving this 4 ml into 3 divided doses. And IUI will be done 35 hours after the first dose. Now what we are doing, that every agonist injection which we are giving, that will be having flare effect, and that is giving that LH sustainable. So that LH is not dropping immediately in that next 20 hours because every agonist that injection is going to give that LH level, and there is sustainable LH level will be attained. And then after IUI, you give luteal phase support. So we are purposely giving oral progesterone, dufaston, as luteal phase support, not giving HCG, not giving vaginal progesterone, because oral progesterone, duphaston, is not measured at serum progesterone. We are doing mid-luteal progesterone when we are giving this modified leupride trigger in mid-luteal phase. And believe me, for all the patients, this progesterone level had come above 25, and even many of them have achieved the pregnancy and are continuing the pregnancy very well. Now, coming to whether we can give dual trigger in IUI cycle, we can give when we are not having a risk of OHSS, and the studies prove that dual trigger may work better compared to SC trigger, and the additional effect of that FSH NIC can be utilized even in IUI cycle as well. So in PCOS, segmentation of the cycle agonist trigger is very safe. Rather than cancelling the IUI, you can go ahead with modified leupride trigger when we have multiple follicle recruitment. Nowadays, even we have 2 follicles in IUI, we are giving this modified leupride trigger and getting very good results. In patients, when we have to decide about the trigger criteria depending on the size of the follicle, catch the follicle younger, and even the follicle is between 16 to 18 millimeter with good endometrial thickness. Let's not wait till 20 millimeter before her innate LH surge starts, and then we can give triggers safely. So thank you so much. This is what all about trigger, which I want to give the brief about.
Thank you, Dr. Shariyu. That was a very lucid presentation, and I think a very important one, and taking us all through the nuances of how to trigger and when not to trigger also.
Thank you.
And your modified leupride is something that I think we all will take back home. That is an interesting thing that you are doing. So I think that's something all of us have learned new. And if there are any questions, I'm sure we can take them. And now I think at the end of the session.
Dear Dr. Shariyu, it was really wonderful.
Thank you, ma'am. Thank you so much.
And really new concept and very good studies.
Thank you.
Yeah, I like the part about the empty follicle syndrome as well. I mean, why one of the reasons why you could be getting that, because many people say that something like this does not exist. Empty follicle syndrome does not exist. So, I mean, it was really good, insightful on what you spoke, how the trigger may fail. So,
yeah, and PPS also, delaying of delaying of ovum pickup timing will definitely make help, because the maturation takes quite late and the ovulation also takes very less.
Yeah, one of the practical points about this is that these urinary gonadotrophins, HCG, requires cold chain maintenance, whereas the recombinant doesn't. That's why many times the urinary fails and the recombinant is successful.
Mm-hmm. Yeah.
Because recombinant, it works even if you keep it at 25 degrees, whereas the urinary ones, you have to maintain between 2 to 8 degrees. That's the most common cause of empty. Actually, there is no empty follicle. The follicle always has an oocyte inside it. Unless it gets an LH surge, it's not going to separate. That's all.
Any questions? We can take otherwise.
We'll have a group photograph. I think I request everyone to open the windows.
That was indeed a very informative session. Thank you, speakers, Dr. Shariyu, Dr. Shweta Mittal ma'am, and thank you, chairpersons, Ritu ma'am, and Dr. Ritu Dargan ma'am, and Dr. Manjushri ma'am.
Thank you so much.
Thank you.
Dr. Manish is there? Dr. Bindu?
Dr. Manish had to log out due to an emergency. He has an emergency OT. So
You just can sum up. Someone can sum up. Ritu, just can you, someone just sum up all the
Yes,
things? And,
yes, I think it was a wonderful
Ritu.
session, and all thanks to Bindu ma'am for having all of us here. And I'm sure all of us are going back much wiser and learned a lot of new things also, especially people who are starting into IVF and are new into it. A lot of nuances that need to be looked at, and like ma'am said, there's no such thing as an empty follicle. It's usually the trigger that you go wrong in. So there's a practical takeaway home messages which are of use. Dr. Shweta Mittal's talk on adjuvants also give an insight as to which adjuvants to use and which have an effect and do not. And Manju ma'am's talk again on stimulation protocols was, as usual, par excellence. And Kulkarni sir, I don't think he needs any more. I think sir's talk was again exceptional. So thank you everybody, and thank you, Vindu
Thank
ma'am,
you
for
very much,
having
all of you. Thank you very much.
Thank you so much.
Bye.
Thank you.
And these are all the faculty which not only give us new things, they give us the practical tips and tricks on how to go about and where we could be going wrong. So thank you so much for everyone for sparing the time with us and sharing your knowledge with everyone here. So thank you so much once again to all our faculty.
Yeah, thank you. It
And
was a
hope
wonderful
to have
session.
more such sessions. As Dr. Manju said, webinars have become a convenient medium for us. Such a sasta sundar tikau medium, I must say.
Yes.
Yes. So
Thank you, ma'am.
so much, one and all.
Riju, you did very well. Riju,
Yes.
you conducted
Yes,
very
special
well.
thanks to Riju.
Really.
Thanks to
Riju,
all
it
our
was
faculty
very nice, huh?
speakers,
Riju,
all
this
chairpersons, and of course, MOC is wonderful.
all reins
Thank
were
you
with
so
the
much.
Riju's hand, na? So she did very nicely.
Thank you so
Thank you
much.
so much. Thank you so much.